Welcome, dear friends and seniors and delegates for the first ICOG certificate course on PCOS, which is starting very today from 29th January, 30th and 31st with 10 ICOG credit points. And do remember to join all the 3 days and do remember to give your post test. And let's take the blessings of Almighty before we start our course.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः।
For the beginning, I would like to invite our dynamic president, Dr. Sunita ma'am. Can we have a CV, please?
Rakhi, this is so much academic. Please don't show CV.
Okay, ma'am.
I humbly request you.
We've got our dynamic president, Foxy, who's started her work in a bang with a bang, and we want to have words of wisdom from you, ma'am.
Thank you, dear all. Foxy ICOG, our academic wing, always does a fantastic academic sessions. Time and again, it has been proved. And today, I joined 5 minutes to 4, and there were 222 people already joined. Shows the interest in this online certificate course. Dr. Parag Biniwale, ICOG chairperson, and Sarita Bhalerao, the secretary, they must have done entire year, they have taken and they will be taking with their various academic programs our ICOG to another height. Dr. Suvarna Khadilkar, she is our Secretary General, second Secretary, female Secretary General. Always proud to have her with me. And I think it's always great to have a like-minded people in the team. The conveners of this program, Rakhi, Seema, and Chaitanya Ganpule, when I saw this flyer, I thought it's a very rightly chosen because Rakhi just finished endocrinology chairperson, Seema being a IVF consultant, and same with Chaitanya with endocrinology committee. They are apt, and Preeti, Shweta, and Garima, the youngsters with their enthusiastic. Whenever we talk about the PCOS, always Dr. Durusha, who made us proud on international platform by coming out with the society PCOS, she being there as a chief guest again shows intricacy of this program. And I'm very thankful to all the past chairperson who are here, Uday, Mandakini, and the fantastic program which has been curated down with the topics, with the panel discussions. I think it will be one of the great PCOS series anyone will have. I think after these 3 days, those people will be masters of PCOS. But only one thing I would like to say, many a times patient with the infertility issue comes, we just tackle PCOS with infertility. When adolescent person comes, we tackle only with the irregular menses problems. So it's very important, anytime we got the PCOS patient, we should sit and talk to them about, we have to take out 5 minutes extra to educate them, to maybe giving them more informative material, because the Google can give out any wrong things. It's a chance that you got this young girl in your cabin, explain her everything about the PCOS, the way it will pause the problem in adolescent, in the reproductive and perimenopausal, postmenopausal age group. So that girl will take 100% effort, especially it's a obese PCOS, which we all know is the majority. And she will ensure that she controls her lifestyle, she controls her weight, and then she can conquer her PCOS related all the endocrinological issues. So my always request, even to my resident, is always the same. They come with the irregular menses, just don't shout out about irregular menses. Try to educate them with the right way about this pathophysiology, about PCOS. And I'm sure everyone in this group will do the same with these online courses. I think 307. Parag, congratulations, Sarita, and the entire team. Fantastic. Thank you. And thank you for having me with you all. Always pleasure to be with you all. I just want to remind 8 p.m. every day, Gyan Pravaha from today. One chairperson, one evening. Please don't forget to log in. It's not just the academic, it may be social, it may be some artistic, it may be the politician who will be coming. And today, the opening batsman is Anu Chawla, who is coming with Adam. Everyone wants to hear Adam. And fortunately, we are with the PCOS. So don't forget to log in at 8 p.m. for Gyan Pravaha, not only today, every day with different committee chairpersons. Thank you.
Thank you, Dr. Sunita, for the kind words and encouraging words. And we move on ahead. We've got our ICOG chairperson, Dr. Parag Beniwale. Can we have words of wisdom from you, sir?
Thank you, Dr. Rakhi. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to share the virtual dais with President Dr. Sunita, Chief Guest Dr. Durusha, of course, past chairpersons of ICOG, the office bearers of ICOG, and Foxy. Welcome to the first certification course of this year, and I look forward to a lot of such activities which would definitely give good knowledge to our Foxians, not only Foxians, even others who are interested in learning. PCOS, we thought of having this as the first program because this is a challenge, and I'm sure everybody sitting here is facing it day in and day out. And we could not have asked for a better chief guest than Dr. Durusha, who's been a past president of Foxy, past chair of ICOG, and of course, she's the creator of PCOS Society of India. So happy learning to everyone, and I look forward to seeing you all again and again. Thank you.
Dr. Parag. And I would like to, since we have Dr. Suvarna Khadilkar, our very own Secretary General of Foxy. She is the second one in the row, the female Secretary General of Foxy. Can we have the pearls of wisdom from you, madam?
Thank you so much. Good evening, one and all. Our President, Dr. Sunita, our Chairperson, Dr. Parag, and Dr. Sarita, who is the ICOG Secretary, and our Chief Guest, Dr. Durusha. I think we all are blessed to have you all here, starting with the first program on PCOS. I think this is the first program of this year, but all of us know that since 1930s, we are just struggling, investigating, researching just to know why this PCOS occurs and what is the exact pathophysiology. Even though we have decoded many aspects of PCOS, still a lot has to be discovered in future, and the programs like this and with the experts like all of you here, it is going to be a treat, and it is going to be thought-provoking to everyone. And I really appreciate the efforts which have gone in by Dr. Sunita, Dr. Parag, Dr. Ashok Kumar, Dr. Sarita, and our conveners, Dr. Rakhi, Seema, Chaitanya, and coordinators, Dr. Preeti, Dr. Shweta, and Dr. Garima, and all the excellent faculty that you have gathered here. I always feel somebody requests you to take a lecture on PCOS, but it is look at this program for 3 days. I will say even 7 days will not be sufficient to cover all aspects of PCOS. There is so much to discuss. So actually we have, in the this particular program is going to cover over all 3 days, I think right from 4 to 7. So 3 hours a day. It's going to be an academic treat, thought-provoking, and all the faculties who are going to do justice to this. And I can see Geeta, Uday, and Sampat Kumari chairing the session. And during Mandakini Mix chairing, when she was the ICOG chair, I was a regular a speaker at this PCOS certificate course, and it used to really run so well. I can see now 360 members have logged in. So I congratulate all of you for this. Then I also see Basa, Meenu, Dr. Chaitanya, Shobha, Raki, and so many panelists who are going to discuss lifestyle modifications and prevention strategies of PCOS. I wish you all a very happy learning session here, and I hope you enjoy and go back with academically rich content of this of this course. Thank you so much, Sarita. Thank you for calling me and reminding me about this course. Thank you. Bye bye.
Thank you, Dr. Sonia, for your kind words. I would like Dr. Sarita ma'am to, the Secretary of ICOG, to kindly invite Dr. Durusha for the chief
Thank you,
guest.
Raki. I am delighted to welcome our chief guest, Dr. Durusha. Madam is the founder president of the PCOS Society India, and under her leadership, the organization is doing tremendous work on sensitizing the public and creating awareness about PCO. Madam is also the past president of FOXY. She's been past chairman of the ICOG. She's past president of the Mumbai OBGY Society and of the Indian Menopause Society. Her work in women's health has been acknowledged nationally as well as internationally, and she has received many prestigious awards. The most prestigious awards being the Honorary FRCOG from the RCOG UK and the FIGO Distinguished Service Award. Thank you, Madam, for joining us, and we request you to say a few words, please.
Thank you very much, Sarita, and of course the leaders at ICOG for having invited me. All of you, Sunita, Parag, Ashok, I will call you all by your first names because I know you all so well. So thank you very much, entire ICOG team, for inviting me. It reminds me of my days at ICOG when I started as a secretary. And then I was there for almost 8 years, because those days every term was for 3 years. And one thing is for sure that I feel proud about is I struggled to start the certificate courses at ICOG, because I felt that our young doctors who do not have the funds to travel abroad and learn, IVF, or learn about endoscopic surgery, or learn about sort of advanced ultrasound or perinatal medicine. I had to struggle, and I had to literally, fight for these certificate courses. Luckily for me, I had Dr. Usha Saraya as the vice chair, Professor Rohit Bhatt as the chair, and they were very, 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 encouraging, and they asked me to go ahead. So during that tenure, we created 4 certificate courses, which started off with a small amount of money to be paid for all that 6 months was 50,000. And I think today I'm so happy that every course is doing beautifully well. Reproductive medicine, endoscopic surgery, everything. So I'm glad that I initiated this program because of the young people in our organization who have benefited from it a lot. And of course, now we are thinking of fellowship courses, which will be longer rather than just 6 months. We are happy that I started the newsletter of ICOG for ICOG Campus, and that I think is still continuing, the ICOG Campus, which has been there. We were the first to start with the ICOG conference, which was in Goa, and that also did extremely well. And what I'm also happy about is there were 2 things which I took to the government. The first thing was that I said, we must help you in all our agenda, which we have for maternal health. At that time, as FOXY president, before I was FOXY president and then chair of ICOG, I said, mothers are dying of anemia, maternal mortality is high, 400 per 100,000 live births. We feel very embarrassed to talk about it. And so I spoke to them and I said, why can't the private sector help me? They said, do you have any, I had a meeting with the health secretary and minister. Do you have any accreditation criteria, they said? Do you have anything to say that you'll competent enough. Can you believe that? Competent enough to handle our public, clientele. So I said, no, we don't have anything in place, but we will create it. I was very positive. They said, how long will you take? To be honest, I never knew how long it takes. I said, maybe 6 weeks. Everyone had a good laugh. And then they agreed to give me the funds. WHO gave us about 40 lakhs to work on the accreditation criteria. And through the accreditation criteria, which we created, I had Sanjay Gupte and Hema Divakar as on my team as the vice chair and secretary. We went to about almost 27 places where we brought in 5 districts, where we brought in the private practitioners and the doctors working in the public sector together, and we said we'll fix a rate for every delivery. So we fixed the rate for delivery was 3,000 rupees, which includes the hospitalization and the doctor's charges. I was very happy that Foxy members agreed to work on it, gave that information to the government, and the government included us in their NRHM program. And I said, if we are doing so much for you, why can't you do something for us? So most of our doctors had major challenges where they had to have separate licenses for separate things, MTP license, tubal sterilization license, nursing home. I said, bring everything under one window, and I think that will help us a lot. So they did that. They've published 2 beautiful books where they have complimented ICOG and Foxy for having created the guidelines. They're available on the website, and you should be able to look at it. Following that came, once the criteria were developed, they have used this criteria to involve the private practitioners into the program. And today we know that there's a lot we have been able to do to reduce the maternal mortality in the country. The second thing which upset me always was that why are women dying of anemia? When the government is giving them oral iron, giving them everything, but then we realized during our Ganga Yatra that women were not taking the iron and calcium. They were not taking the folic acid. And we interviewed at least 1 lakh women along that route. And we found that they were not taking it because of the side effects of it. So I approached the government as the ICOG chair, and I said, can we give intravenous iron to the women rather than waiting for them to take oral iron? And they said, yes, but where is the proof to show that it is safe? I said, we are all using it in our private sector. They said, no, but we need the proof. So I connected with Public Health Foundation of India. There was 11 crore grant given to them to work on this IV sucrose. 4 years we worked in 5 major districts of the country, states of the country where maternal mortality is highest. We got the data published in the Lancet. With a Lancet copy, I went to the government and I said, now here's your proof. Today, I'm happy to say in all the primary health centers all over the country, intravenous iron is being given in their 4 mandatory visits on prenatal. So my only suggestion is that, yes, we occupy positions. Let's do justice to those positions and do something for the women's health in this country. And that is the reason why I started PCOS Society 10 years ago. Because most of the conferences, there was just 1 hour dedicated, somewhere something was talked about. And I said, we need to do much more. Started it as a multidisciplinary organization. And we have actually 4 certificate courses already available. The basic PCOS course was launched 9 years ago. It's available on our website. We have the basic course in PCOS. We had books made, distributed to everybody. We had the expert course, which is related to infertility. We have the adolescent course, which is done in collaboration with International School of Gynae Endocrinology. And we have the impact course done with the SNDT University. All these courses are available free except the impact course, which is in collaboration with SNDT University, where nutrition is being discussed with PCOS. That is a paid course, and the rest are all free, available to you. And this is what I wanted to say, that yes, we have come a long way with PCOS, and I'm glad to see that every society seems to be on the same bandwagon. Everybody's wanting to do on PCOS, and I think I'm very happy. But let's work towards creating some research on PCOS. That is what will interest us. And if ICOG is happy to conduct this research in collaboration with PCOS Society, I will be absolutely delighted. We will work on it together, and this is something which I'm truly looking forward to, because we need data from our country. And I wish all the best to you for your course, and hopefully we will work together. Thank you so much for having me.
Thank you, Dr. Duru ma'am, for your kind words, and I hope everybody must have got benefited with that. And let's move on and start our course. And for the today's course, we have got lovely set of topics with us. See, any female who is pregnant will not be pregnant only with her child. She is also pregnant with her grandchildren and the great grandchildren, because genetic modification is now seen in PCOS, and thus we have got a topic which explains at us at length about in utero origin of PCOS. And there are various phenotypes of PCOS which are available. We need to classify them, which all types of PCOS are there and how. But we all know that hyperandrogenism is the basis for all the different types of PCOS. And with these symptoms, the PCOS is also on a rise, and irregular cycles are common. With hyperandrogenism, there is hirsutism, acne, alopecia, acanthosis nigricans being seen. And with all these symptoms in adolescent PCOS, there would be body image issues, there would be the other all issues which would be present, and which needs to be addressed for all these patients. And we should always not label adolescent with PCOS. We should always be labeling them at risk for PCOS, as the HPO cycle takes around 3 years from the menarche to get settled. And on ultrasound, that is PCOM on ultrasound for the diagnosis, it takes 8 years from menarche to label these patients as PCOS. For these adolescents, definitely for that reason, we need to label them as at risk for PCOS. And early diagnosis is important for these patients to instill early lifestyle modification, which will prevent the reproductive and the metabolic complications, which can be prevented. And we've got a lovely co-moderator with us, Dr. Preeti Vyas. Can we have her CV? She would be taking the whole program ahead about adolescent PCOS today with us. Dr. Preeti Vyas is a senior consultant and obstetrician at Hinduja Healthcare Khar Hospital and KLS Memorial Hospital and Surya Mother and Child Hospital. And over to you, Preeti, to take the proceedings.
Thank you so much, Dr. Rakhi. I'd like to first thank everybody for giving me the opportunity, especially Dr. Rakhi, for having the faith in us and giving us the opportunity to take this forward. PCOS, of course, is something that is dear to all of us, and let's start our sessions. We have the first session chairpersons here with us. Nilima, can you share the CVs? So we have first with us the chairpersons, Dr. Sampath Kumari Madam. Dr. Sampath Kumari is a senior obstetrician and gynecologist, FOXY Vice President of the year 2023. Madam has been the recipient of multiple awards, including the Dr. Durusha Madam's Distinguished Community Service Award, the FOXY Dr. N.A. Pandit, as well as Shailaja Pandit Women's Empowerment Award. She's also received the Karamveer Chakras Award. She has more than 200 publications and papers, and Madam is a very strong advent worker. We have with us Dr. Uday Thanawala sir. Sir, of course, is a dear friend and is also has been the ex-past chairperson as well as the past vice president of FOXY. We have with us Dr. Geeta Balsarkar. Dr. Geeta Balsarkar is right now the secretary of Mumbai Obs and Gynec Society. She's also the editor emeritus of Jogi as well as editor in chief for IGIFM. She, of course, has been the former president of the AFWI as well as the Mumbai Menopause Society. So, can I please request our esteemed chairpersons to start the session? We can start with the first talk, and can I request Dr. Uday sir to please introduce the first speaker, Dr. Rakhi Singh, Dr. Sarita Madam, Dr. Sarita Madam.
Thank you so much, Preeti, and welcome to all of you to this wonderful course, which has been so well detailed and taken, covering all aspects of PCOS. And since Rakhi has already elaborated on the topics to be covered by this, I will just tell you about the speakers. Dr. Sarita Bhalerao is the present secretary of the ICOG in here, and she is doing wonderful work. Besides that, she has got very keen interest on the colposcopy, the cervix, and in general everything. She's an all-rounder. So Sarita is here to take the first topic on the in utero origin of PCOS. And after that, we will have Dr. Chandrika Anand, followed by Dr. Basab Mukherjee and Dr. Meenu Handa. A word about Chandrika Anand is that she's a very keen worker on PCOS and she's done a lot of research in her own center. So it'll be a pleasure to listen to all these speakers. So don't go away anyway, but we'll start with Sarita first in the in utero origin of PCOS. Over to you, Sarita.
Thank you very much, Dr. Uday, for that kind introduction. Am I audible? Can you hear me?
Very well.
Yeah, thank you so much. My talk today is on in utero origin of PCOS, and I'll take you back to the time that Stein and Leventhal described PCOS almost 80 years ago. And even though we've had so much clarity, we still don't really know exactly what causes PCOS. We know that PCO affects women of reproductive age, but the exact cause is still not completely understood. And though we've thought for many years that there is a strong hereditary component, no candidate gene has been isolated. Recent evidence does suggest that the intrauterine environment may be one of the key factors in the pathogenesis of PCOS in later life. And so, a woman, when she is a fetus, if she is exposed to hyperandrogens, that may be the beginning of the PCOS. And this hyperexposure of the fetus to androgens in utero has several effects. And now we have animal studies as well as human data to support this hypothesis, which is what I'm going to discuss. So it was Barker in 2002 who described the developmental origins of adult disease. And what he said was that influences on fetal development later on cause permanent changes in the offspring physiology and metabolism after birth to such an extent that they may present with these effects many, many years after being born. And it was Barker who said that low birth weight leads to the adult development of cardiovascular disease, hypertension, insulin resistance, and type 2 diabetes. It was Neil in 1962 who said that fetal stress from maternal undernutrition leads to obesity and diabetes later on in life when food becomes abundant because the genes are programmed in a different way. Maternal overnutrition, in the same way, leads to an increased chance of metabolic syndrome. And the phenotypic expression of PCOS through altered maternal and endocrine metabolic environment leads to epigenetic modifications, that is, modifications in the genes and the way the genes are expressed. So, IUGR in utero can lead to insulin resistance in later on and can then lead to the metabolic syndrome in the postnatal life. So, what is epigenetics? And epigenetics is the really means the modification of gene expression. It's not that the genetic code is altered, but the gene expression is altered. And what we know about PCOS is that the etiology is multifactorial. It may be genetic, it may be environmental, and it also may be something called epigenetic. We have enough evidence to show that in twins, there is monozygotic twins, the chance of PCOS is 71% when one twin is PCOS, 38% when they're dizygotic. Mothers and daughters transmit PCOS phenotype just as sisters share PCOS phenotypes. And parents of PCOS women have a higher risk of metabolic dysfunction. So, all this points to a genetic etiology. And though many genes have been associated, no one gene has been found responsible. So the maternal environment is very important, and hyperexposure of the female fetus in utero to testosterone has been supposed to be causing this condition Because mid-gestation maternal testosterone levels correlate with high AMH levels in the adolescent female offspring. So they looked at the mother's testosterone levels when they were high. They looked at the AMH levels after in the offspring, and they found that they had high AMH levels. And this process may affect the expression of genes concerned with ovarian steroid production, insulin action, GnRH pulsatility. Also, these offspring had higher fasting and 2-hour postprandial insulin levels. Now, Roy Hamburg and Panagotta Filipao have this beautiful diagram where they show the influence of the maternal environment of a woman with PCOS. And they show that that maternal environment is affecting the placenta in so many ways. It is affecting the enzymes of the placenta, it is affecting glucose transport, and then in turn, it is affecting the fetus, predisposing the fetus to PCO metabolic conditions, insulin hypersecretion, androgens increased from the fetal ovary. And that is how they have suggested that PCOS has an in utero origin. But having said that, not all fetuses who are exposed to this hyperandrogenism develop PCOS. And why is that? So there's a counter argument which says that the human fetus is actually protected from maternal androgens. There's a high concentration of plasma binding proteins in pregnancy, so much less testosterone is free. There's a high level of placental aromatase, which converts that testosterone into estrogen so that it doesn't reach the fetus. So, is it that the placenta of PCOS women is dysfunctional? Are there changes in the placenta? We don't really know. Animals in all these studies have shown they have tried treating mice with androgens and found that their oocyte mitochondria affected. They also had a lean mouse model where they found mitochondrial alterations. In one study, they gave AMH prenatally to mice and induced a lean PCOS phenotype in the offspring. And dams treated with AMH had female pups who had a higher testosterone and luteinizing hormone in the neonatal period. Again, suggesting that PCOS programming starts in utero as early as in utero. So it was Maya Baski from Houston, Texas, who said that some PCOS phenotypes can be programmed in utero through an altered androgen environment, causing changes in gene expression and mitochondria, which could then be transferred to future generations and exacerbated by excess androgens. And it is this in utero androgen exposure which first starts the epigenetic changes, which leads to propagation of impaired mitochondria, which goes from generation to generation. And so she said one path that leads to PCOS begins at birth and is programmed in utero by androgens. And this inheritance pattern is due to in utero androgen programming on gene expression and on mitochondria. But there's a beautiful debate in fertility sterility. Does PCOS have developmental origins? And there are arguments on both sides. So it is not only the in utero influence, there is something more than that. Yes, there are genetic factors which have an important part to play, and it's a disorder which begins very early, maybe in prenatal life. That capacity to hypersecrete androgens begins in fetal life, and the clinical and biochemical features are all downstream effects. The phenotype, but, is influenced by something more than just this. And what is the source of excess androgens? And at what stage of development does it actually exert its effects? These are unanswered questions. And the counter argument is that PCOS is not purely developmental because all female fetuses exposed to an unfavorable milieu don't develop PCOS. So is the developmental window strictly intrauterine? No, the developmental window remains open for as long as we live and our epigenome is continuously being remodeled. So what is PCOS then? It starts in utero and it goes on later. And so we have this concept of a two-hit hypothesis, where a fetus in prenatal life is exposed, and that's the first hit, which leads to endocrine metabolic imbalances and programming. And there is a second hit, which occurs later, and postnatally, which then leads to adult disease and which gives us a chance to reverse these changes or at least prevent these changes from happening. So now that I've told you the problem, I need to tell you the solution. What is the solution to all this? And the solution is that we have to start very early in life. And in adolescent health, we need to encourage women for sports. We have to understand and support women with PCOS so that they enter pregnancy in a good frame of health. And lifestyle interventions have to start in childhood, have to start in adolescence, and these will improve the free androgen index, weight, and BMI. And I think now, with changing trends, there's a tremendous focus on sports, and hopefully, this will change. As obstetricians, we need to optimize pre pregnancy health and create awareness among our patients about the risks of PCOS in pregnancy. Encourage them to exercise and eat healthy during the pregnancy. And the importance of a multidisciplinary team, including an endocrinologist and a nutritionist, before they enter pregnancy is very important. I think personally, family counseling is very important, especially in pregnancy. And we need to dispel myths like eat for two and heavier the better. Assessment of type 2 diabetes with an OGTT test is advisable, and lifestyle management, weight management, and weight loss, pharmacological management, even bariatric surgery if they have morbidities and if BMI is very high. One of the things that we can all do is metformin use, and metformin is widely offered, inexpensive, and safe. We do know that it reduces the risk of miscarriage and preterm labor, and it can affect insulin resistance resulting from fetal programming, and epigenetic changes can perhaps be reversed by metformin. Metformin leads to healthier fat distribution, less visceral fat, and less insulin resistance. And so, metformin started before pregnancy and continued in pregnancy will have benefits both for the mother in reducing gestational diabetes, gestational hypertension, and preterm labor, and also for the developing fetus, including early pregnancy loss and fetal growth restriction. Another tablet we can use is myoinositol, which is a naturally occurring sugar which modulates insulin resistance and is a mediator of insulin signals and will reduce the incidence of GDM, PIH, and preterm delivery. So, as I say, PCOS is a multidisciplinary team management with a dermatologist, endocrinologist, gynecologist, nutritionist, tremendous counseling, psychiatrist, maybe even a bariatric surgeon. So, put it on. And this is what we require for our patients. And as I end, I say that childhood obesity is also very important when we look at the two-hit hypothesis. When increased androgen levels and childhood obesity at 14 years gives 61% chance of PCOS at 31 years and the expression of PCO traits. So weight management is a very important strategy even in childhood for obese and overweight patients. So as Dr. Saravanan from Madurai says, take care, eat healthy, stay active, and remember that when you are pregnant, you are also pregnant with your grandchild. So let's try to identify women at risk, modify the environmental determinants which are in our hand so that we can prevent PCOS in those whose genotype or previous exposures put them at risk to develop outright disease. I thank you all for a patient hearing.
Thank you so much, Sarita, for that lovely lecture. It would be of a little bit of interest for you to also know that when you talk of in utero development of PCOS, there are some papers now coming up on the effect on the uterus, and they say that malformations like a unicornuate uterus also could be the result of exposure to higher AMH levels in utero when the fetus was in utero. So it is all combined, the uterine structure, the ovarian structure, etc. So excellent lecture. And I think we want to keep questions for the last, right, Preeti?
We'll have questions in the chat box only.
Questions will be in the chat
So
box.
chat box, Preeti, you have to look after and just
So
take
there
out
is,
duplicate ones and tell us. So in the
can I ask
meantime,
one question right now for Dr. Sarita Madam?
sure.
Yeah, sure, go ahead.
So somebody has asked, can metformin and inocetal be given even with OGTT in pregnancy is normal?
So I think we need to see that on an individual basis. And if your the OGTT is normal, then the patient may not be insulin resistant. So I think we need to evaluate that on an individual basis and see whether they really need it. We can't over give these things, but we definitely need to give it in when it is needed.
Also, second question, can myoinositol be given in
I
pregnancy?
think
Is
Preeti,
PCOS
I'll answer these in the chat box because we are running late
late?
ahead of
It's
late.
9 o'clock.
So I'll answer all the questions in the chat box.
Yes.
So can the other speakers. You can go ahead.
Yeah. So can we have Dr. Sampath Kumari Madam? Are you there, Madam? Will you be able to introduce our next speaker, Dr. Chandrika Anand? Nilima, you'll have to put the slide up, please. I think Madam is not there. Dr. Geeta, are you there?
I think I'll introduce
You
Chandrika.
will introduce her.
She's a very flourishing practitioner in Hyderabad, right, Chandrika?
Bangalore, sir.
In Bangalore, and she's got a big center there. She's doing a lot of research work on PCOS. A very, very keen member of the PCOS Society, and that's how I've been associated with her. She has brought a lot of studies to the table, and we'll hope to do it. But she has a what she calls as a PCOS center in Bangalore and a South Zone coordinator of the Endocrine Committee and managing committee member of the PCOS Society of India. Besides all the rollers of gold medals, etc., which she's got in MBBS date. But her topic is interesting and something I would like her to clarify for our audience is the phenotype and the genotype of PCOS. Go ahead, Chandrika.
Yeah, thank you, ICOG. Thank you, Foxy, for this opportunity to talk about very complex or how many ever times we read the pathophysiology of PCOS is very, very eluding. But thanks to Sarita ma'am, which she made it very easy for me to explain the pathophysiology of PCOS because everything starts from, most of the things starts from the in utero or the fetal development or fetal origin of the PCOS. So I'm going to rush through the pathophysiology aspect and the phenotypes and why we should be phenotyping at all the PCOS. Now, there are very, very three important things which happen in PCOS. One is there is hyperandrogenism. Second thing, there is a aberrant gonadotropin releasing hormone pulsation, which results in increased LH and reduced FSH. And three is insulin resistance. So there are three things: excess androgen, abnormal GnRH pulsation, leading to increased LH and insulin resistance. These three comprise the vicious cycle that underpins the pathophysiology of PCOS. Now let's start with the GnRH levels and the PCOS. Now everything I'm going to touch on the clinical aspect of it. So we don't know where it starts. Does it start with the hyperandrogenism, ovary, brain, or the insulin or the fat or the adipose tissue? But they all seem to start together or maybe start at one point and then spread over to the other 2 points in a genetically susceptible female. So the GnRH levels, there is an abnormal pulsation. They have found that there is increased levels of chemicals like kisspeptin, GABA, and the AMH, which will stimulate abnormal GnRH pulsation, which increases the increased LH and reduced FSH ratio. Once there is an excess of LH, this LH stimulates the theca cells to produce more androgens. See, the theca cells, the two-cell theory of steroidogenesis in the ovary, the theca cells using the cholesterol as a substrate, it will secrete till the androgen or the testosterone, and this will travel to the granulosa cell and gets converted to estrogen. But LH will stimulate the theca cells to produce a lot of androgen, and this causes ovarian dysfunction. This LH also increases the AMH, which in turn goes back to the brain and causes more abnormal GnRH pulsation. This is why the sleep cycle, reduce the sleep cycle, disturbed sleep, sleeping late in the night, having stress, anorexia, too much of exercise, all these things, why they interfere with the regularity of the cycles and cause PCOS is explained by this central level of pathology. Next is the hyperandrogenemia, which is a very, very, very important aspect of PCOS. It not only causes PCOS, it also affects the PCOS, the future complications of the PCOS, the phenotype of the PCOS woman, how much complications she is going to have, how much cardiovascular problems she is going to have, and if she becomes pregnant, just like Sarita ma'am told, how much that is going to affect not only her child and also the future generation depends on the excess androgen in the blood of PCOS women. Now, what makes this? Where is the source of androgen? We know the most source of androgen is the thecal cell of ovary. There is an increased adrenal androgen also, and there is increased androgen secretion from the adipose tissue. Now, again, what makes this ovary to produce more androgen? We start from the GnRH abnormal pulsation. There is hypersensitivity of the thecal cell to LH hormone, and also insulin resistance or excess insulin stimulates the thecal cell to produce more androgen. So this androgen is pumped to the blood by the ovarian thecal cells, by the adrenal androgens, and also from the adipose tissue. Now, the third culprit is the insulin resistance in PCOS. So, just like Madam told just now, the genetics, epigenetic changes in obesity, all these in a person who is genetically predisposed to insulin resistance, all these obesity, inflammation, endocrine disruptors, dietary factors, mood disturbances, depression, environmental toxins, all this will exacerbate or start to trigger the insulin resistance or the hyperinsulinemia. Now, what is insulin resistance? It is a condition in which more insulin has to be secreted by the pancreas to maintain the glucose homeostasis. So, because there is a resistance which is happening at the post receptor level, so there is a defect or the post binding defect in the insulin signal transduction, which will lead to insulin dysfunction in women with PCOS. There is an abnormal signal in the post receptor levels, so this will cause excess of insulin in the body. This insulin can cause two things. One is metabolic abnormalities, second is reproductive abnormalities or reproductive failures. How? Now, this excess insulin will trigger increased LH secretion, increased GnRH secretion, increased ACTH secretion, and also the increased androgen. And on this excess insulin on the skeletal muscle and the liver and the adipose tissue, it increases the glucose levels, reduces the sex hormone binding globulin, which in turn increases the circulating estrogen levels. So this excess androgen and insulin, they are linked to each other. How? So now we understand there are three main things. One is the abnormal GnRH pulsation happening in the brain. Second is the hyperandrogenism happening at the ovary, adrenals, and also the adipose tissue. Third is the insulin resistance. Now, what causes first? There has been a very, very long debate whether it is excess androgen or insulin resistance. Both are linked to each other so intricately that excess androgen increases the insulin resistance increases the excess androgen. It is a vicious cycle. That is why when we are treating the PCOS woman, why should we understand all this? Because in the lifestyle, we need to lose weight. We need to advise at least 5 to 10% of weight reduction, which will reduce the insulin resistance, which we have noticed that it will also reduce the androgen levels. At the same time, when we are giving anti-androgen medications in the form of COC or the anti-androgens, even the insulin level comes down. The origin of this vicious cycle is still unknown. The simplest explanation is that for this complex and heterogeneous syndrome would be hyperandrogenism is a predisposing factor, as Madam told, whereas insulin resistance triggers the development of PCOS. So these two, they exacerbate each other, they fuel each other. So breaking one or treating one will also help the improvement of the other chemical. Now, what is the role of AMH in PCOS? Now, we know that AMH is increased in PCOS. So, elevated LH, elevated insulin, androgen, everything increases the AMH in the blood levels and also in the microfollicular fluid. This AMH goes back to the brain, increases the exacerbate the GnRH pulsatility. So, also it affects the ovulation. It will cause anovulation. Now, how does these three culprits, that is the insulin, androgen, and the GnRH, affect the ovulatory dysfunction? Excess insulin will cause abnormal follicular microenvironment. Androgen excess, it will cause a pro-inflammatory state, and ER stress, which is called. At the same time, there is endocrine disrupting chemicals, AGEs. They all accumulate. There are a lot of toxins which are getting accumulated inside the small eggs. So all these result in apparent follicular growth, which accelerates in the early stage and then it will arrest in the antral stage, causes anovulation and also the interstitial fibrosis. That's it is causing the polycystic morphology in the ultrasound and also the anovulation triggering irregular cycles. Now, this is in summary, what is the pathophysiology of PCOS? So there is this endocrine toxin, the environmental toxins, genetic predisposition, gut dysbiosis, diet, lifestyle. All these will contribute or trigger in a person who is already having a hormonal imbalance, hyperandrogenism, and an insulin resistance. Genetically, if they are predisposed, it will trigger and cause PCOS. Madam has spoken about genetics and PCOS. So we know Madam has told that there are daughters born to women are more at risk, and then the twins, it is more found in more in twins. What about the gut microbiome? Gut microbiome is in the adult patients with PCOS and various models differs from those of healthy individuals. And also when we treat these women with the fecal transplantation or co-housing with healthy rodents ameliorates the PCOS like phenotypes in such models. This is found in rodents. So women with polycystic ovarian syndrome have got higher intestinal levels of Bacteroides vulgaris and the lower levels of the glycodeoxycholic acid and taurodeoxycholic acid. So this is again explained already. So there is a prenatal exposure of androgen. So maybe if we reduce the androgen in a woman who is trying for a pregnancy, maybe preconceptional androgen suppression or 1 or 2 cycles of the COC to reduce the androgens can help the patient to go for a healthier pregnancy. So conclusion about the pathophysiology is that pathophysiology of PCOS is heterogeneous and it is shaped by the interaction of the reproductive and metabolic disorders. Hyperandrogenism and insulin resistance, they exacerbate one another during the development of PCOS, which is also affected by the dysfunction of hypothalamo-pituitary ovarian axis. PCOS is a highly heritable disorder. Exposure to certain environmental factors causes individuals with predisposing genetic factors to develop PCOS, and the environmental factors that drive the development of PCOS makes a larger contribution than the genetic factors and may include the intrauterine environment during the prenatal period, the follicular microenvironment, and the lifestyle after birth. So a little bit about phenotypes, all of us know how to classify, how to diagnose PCOS. There are different criteria. The international 2023 criteria, the new guidelines have come. Rotterdam diagnostic criteria is the one which contains two, if the two criteria is positive among the three criteria, that is ovulatory dysfunction, hyperandrogenism, and polycystic ovarian morphology on ultrasound. These are the three criteria. The hyperandrogenism can be clinical or biochemical. If any two are present, then it is PCOS according to Rotterdam criteria. Now, there has been a subtype called phenotype classification of PCOS. So, phenotype A contains all the three criteria. B contains hyperandrogenism and the ovulatory dysfunction. C contains hyperandrogenism and PCOM, whereas the D, which is the mildest, ovulatory dysfunction and PCOM. Obviously, the mildest because the culprit or the main pathology of hyperandrogenism is not seen in phenotype D. Why should we classify PCOS? Because to study the clinical and biochemical characteristics of all patients, to risk stratify the women with PCOS, to tailor make the treatment strategy, and also it helps in conducting epidemiological and clinical trials and to understand the pathophysiology of PCOS. Type 1 and type 2 are together clubbed as classic PCOS. Now, this is the most severe form of common form and severe form of PCOS. These patients are present as group with abdominal obesity, increased levels of LH, increased androgens, and elevated insulin resistance. And these people are the ones who are more prone for complications, both the reproductive complications and also the metabolic complications, and chronic cardiovascular disease risk is the highest in this group. And the most severe clinical manifestation, irrespective of the PCOM, the hyperandrogenism is the culprit. So phenotype 1 and 2, the classic PCOS, is the most common and the most severe form of PCOS. The ovulatory PCOS, in which there is a good ovulation, but then there is a PCOM morphology on scan and there is a hyperandrogenism clinically or biochemically, it is a milder form of classic PCOS. These patients presented with most characters, but in a milder form. So, in fact, these patients had intermediate values, in between the classic and the controls of BMI, waist circumference, insulin levels, and the testosterone levels. But then it is also known that when the type 1, that is phenotype A and B, if they start treatment and if they start losing weight, and if they undergo good lifestyle changes, they may transit to the phenotype C. So gradually it can be a passage from classic to ovulatory PCOS. Now, the non-hyperandrogenic or the phenotype D, which contains only the oligoovulation and the PCOM, is the least severe or the mildest form. It is so mild that, compared to the controls, it has got very, very few problems compared to the control. So, almost some researchers are almost thinking that it may not be PCOS also. It could be some other disorder, or maybe, aberration of the normal, but it need not be a PCOS. That's what even they are thinking. So now the only problem with this group is that they are more prone for ovarian hyperstimulation syndrome and ovulation induction. Summarizing all the four phenotypes and what is most severe. So phenotype A and B is most severe, C is medium, and D is the mildest. And this is the prevalence in the general population and prevalence in the clinical population. We can see the commonest is the classic phenotype. Now, the one interesting thing is that it changes this phenotype will gradually change as the woman ages, over decades. Every decade, now 596 women were studied in Rotterdam, in Netherlands, and over decades, the diagnosis of PCOS reduced, phenotype A and D also reduced, testosterone reduced, AMH reduced, ovarian volume and the number of follicles also reduced. What increased was BMI, waist circumference, and blood sugars, maybe because of aging. Insulin resistance increased over decades, and phenotype C increased, and hirsutism also increased in spite of normal androgens. So this is about the phenotypes and pathophysiology and phenotypes of PCOS. Raki.
Dr. Geeta?
Thank you so much, madam.
Yeah, I'm there,
Okay.
Ma'am, you
but
can
I'm in the train. So, any of your
questions we take in the chat. So all the speakers will answer the questions in the chat box. And you can use the next speaker, ma'am.
Thank you so much, Dr. Chandrika. I think it was an excellent talk, and especially for all those who are going to be taking the webinar for the learning and for the certificate course. I think it's going to be a great eye opener for all of them. Can we please now have the next speaker slide, Putra? So the next speaker is Dr. Basab Mukherjee. All of us know Dr. Basab very well. Dr. Basab has been the AI's Yuva Foxy organizational role for 2012, the Endo guy in the Boxcon, the Fetovision, has been the vice president of Foxy, is also the member of the PCOS Safe Abortion Committee, chair of IRC, and has been the president of the Bengal Obs and Gynec Society. Dr. Basab is going to talk to us today about how different are adolescent PCOS as far as diagnostic criteria is concerned. And I think that's very important topic, because that's always a googly as to should we label a patient as a MCO, PCO, what are the criteria that we have to take care of while diagnosing an adolescent PCOS. So over to you, Dr. Basab.
Thank you, Preeti. Thank you. Thank you very much. And warm regards to our dear friends Parag and Sarita for the ICOG office bearers now about taking this series forward. And the amount of people who have joined is just an idea about how much PCOS is seen in our clinical practice and how much we all deal with it in our daily lives. Also, greetings to the conveners, Dr. Rakhi, Dr. Seema, Dr. Chaitanya, and the coordinators, Dr. Preeti, Shweta, and Garima, for bringing together this show. Wonderful talk by Dr. Chandrika, and this will be less technical, more practical. I'll just bring this up and start sharing the screen. Yeah, thank you. Should be working. Yeah. So diagnostic criteria of adolescent PCOS, how different are we? So over the next 10 to 12 minutes, we will take you through these a very small part of PCOS, where we talk about diagnostic criteria of adolescent PCOS and why the dilemma and why the question is very asked. So PCOS affects 1 in 10 women is what we talk about when we go in our public awareness meets. But we also know that it may be increasing, and we don't have many more studies. But if you have looking at in the infertility population, infertile population, there'll be much more. In the adolescent age group, also there'll be much more. Includes complex traits from heritable influences, non-heritable intrauterine, extrauterine environmental factors, variations in insulin resistance, alterations in steroidogenesis, and alternative adaptations to energy excess. So there's a huge amount of theories into it. Now coming to the topic directly, why is adolescent PCOS using adult criteria a problem? So I think the important thing to understand is there are several issues. I just want to highlight a few of them. How can we be certain that adolescent hyperandrogenism is not a consequence of the lack of full synchrony of the hypothalamo-pituitary axis during the prolonged anovitreous cycles typical of pubertal development? So when a woman is achieving the extremes of age during puberty, and there is sometimes a little bit of hirsutes as a part of adolescent development. So how do you make sure that that is not being misdiagnosed as PCO, or what exactly can we take in the PCO diagnosis, which we cannot take in the first few years after menarche? And that is why the dilemmas come in, and that is the reason why adolescent PCOS, there are guidelines and there are some studies to show that has to be different diagnostic criteria have to be put for adolescent PCOS in comparison to adult PCOS. So this is what we are going to discuss, and what are the dangers of overdiagnosis versus underdiagnosis. Overdiagnosis is a problem because if you stamp a person of PCO, she is actually stamped for PCO for life. So it is irrespective of whether the ovary has polycystic appearance, because she would have a psychological distress about having the disease and having problems, and a lot of discussion on PCO would be unnecessary if a person does not have the condition. Underdiagnosis is a problem also, because if you do not treat it and she continues to have long periods of amenorrhea and you say that, okay, she's growing up, let's be all right, then that also is an issue, and that is a problem. So we know the Rotterdam classification, the classic polycystic ovary appearance in PCO, menstrual dysfunction, hyperandrogenism. We also know the phenotypic classification with Dr. Chandrika very nicely put forward, and that is something which we usually go by. But for the adolescent, it's a little different, and let's look at each of the phases of where we do. So one of the diagnostic criteria of PCO is the hyperandrogenism. And there are two ways of checking hyperandrogenism. One is clinically, where you take the modified Spearman-Galway score, or you do it biochemically, where you go and do some specific tests to check for hyperandrogenism, usually total testosterone, and we'll come to that in a minute. So these are the two things which you do for clinical hyperandrogenism in general in an adult. Sometimes you don't even do it. You see that yes, she's got acne, yes, she's got facial hair, yes, she's got some balding on the scalp, and then definitely you stamp her as yes, she has hyperandrogenic features. Sometimes we don't even test the levels because we are fairly sure in the clinical features that she has hyperandrogenism, and we label that. But in an adolescent, again, it's different. So isolated mild hirsutism should not be considered in the early post-menarcheal years, where it may be in the developmental phase. So that's a level C evidence. Moderate to severe hirsutism, level B. Persistent acne and poorly responding to topical dermatological therapy, level C. These are some cases, something where we can label them as clinical hyperandrogenism. What about biochemical evidence? Hirsutism, severe acne, and/or biochemical hyperandrogenism confirmed by a validated high-quality assay. So there's a lot of talk about free androgen index, but that's also is not available all over the place. But total or free testosterone is available. Some people do it not just to diagnose PCOS, but to rule out other diseases so that you're not confused with other tumors of the ovary or some other reason why you're doing it. So, but they all vary depending on which lab it's being done, which time it's being done, and the levels of SHBG, which is the binding protein. And so those are the issues or problems with having testosterone measurements. And also the problem of getting a Reliance reference lab where you can have it done. What about oligoanovulation in adolescents? So according to the recent guidelines, you have to wait for at least 8 years if there are irregular periods, no, sorry, 8 years is the sonography. We'll come to that in a minute. So if it's more than 1 year post-menarche, more than 90 days for any one cycle would be used as a diagnosis of oligoanovulation. If it's less than 1 year to more than 1 year to less than 3 years post-menarche, then the cycles less than 21 or more than 45 would be considered abnormal, and more than 3 years post-menarche cycles less than 21 or more than 35 would be considered abnormal. So depending on where she is post-menarche, we have some idea to suggest that whether we can call the oligoanovulation or not. So less than 1 year post-menarche, we don't do any diagnosis. So there you understand that it is again a maturing of the hypothalamo-pituitary axis. So there is nothing to be done there. After 1 year, the actual
I think we have lost Dr. Basa. Gauri, can you check with Dr. Basa?
Yes, ma'am.
Basap has gone offline.
I think there was some internet issue because in between his screen was getting frozen.
We'll just wait for 2 minutes. Otherwise, next speaker will start and then he can complete it after that.
You can call him. He may not know that he's off.
So that's what we doing it.
Should we, Gauri, any contact with Dr. Basa?
आईसीयूजी टीम कनेक्ट कर रही है बस अफसर के साथ कुछ रिवर्ट आया तो मैं आपको बताती हूँ
I think
I'll do what? I'll introduce Dr. Meenu Handa till then. Should I do that? Is
Yes.
Dr. Geeta there to introduce Dr. Meenu?
Let Dr. Geeta introduce the next speaker.
Dr. Geeta?
Dr. Geeta is joined.
Can I introduce the next speaker?
Yes, madam.
Yeah, it's my pleasure to introduce Dr. Meenu Handa, who is specialized in reproductive medicine. She's a gynecologist and fertility specialist at Cloudon Hospital at Golf Course Road in Gurugram. May I request Dr. Handa to take over the mic, please? She's the North Zone Coordinator for FOXY Endocrinology Committee. Dr. Handa?
I think Basab is joined. Why don't we finish his lecture first?
Yeah, let him come.
Basab is joined in. Let him finish the lecture because it was halfway through. Basab, can you just come online, please?
Thank you. So sorry. So sorry. Usually doesn't happen. I'm so sorry. I'll just get it sorted. Thank you there. Thank you. So sorry. Yeah, fine. So sorry. So the last discussion which we were having here is the criteria for evidence of oligoanovulation in adolescents. The last part of the talk, part which I was missed out, was the primary amenorrhea by the age of 15 or more than 3 years of amenorrhea in the post-thelarchy state would be considered as oligoanovulation in this case. So criteria for PCO morphology in adolescents, that is something very important because a lot of times, unless you have a PCO morphology, you can't stamp somebody as PCO, though we know that's not the only criteria. You can do that without the morphology. But PCO morphology is reported as prevalence as high as 30 to 40%. Physiological changes occur in the second decade of life, and ovarian volume starts to increase with the onset of puberty till around 16 years. And a lot of people say that ovarian volume of more than 10 centimeter per cube would be preferable than the follicular counts in a case of adolescent. But generally, we understand that the latest guidelines say that do not use this criteria for diagnosis within 8 years after menarche. So 8 years post menarche, don't use PCO appearance in an ovary as the diagnostic criteria. Go by the other ones. We already mentioned the biochemical and the other ways. So diagnosis of PCOS in adolescents currently hinges on the evidence of ovarian dysfunction and androgen excess. And that's what we were trying to say, and not on the morphological appearance on a sonography. So just summarizing what we have said, the overlap between normal pubertal development and the characteristics or features of PCO may confound an accurate diagnosis among adolescent girls. So we have to be careful before labeling them as PCO, because it may be just a normal pubertal development. So we should follow the advice and the guidelines and the recommendations which are coming up, which say that you don't go by the sonography. That's number one. If you go by irregular cycles, see how many years you are from menarche, and depending on that, you decide whether you can really put them put them in this oligoanovulation category. And about hirsutism, be more definite. You can't go for mild hirsutism, go for severe hirsutism, or you go for a assay of the biochemical markers in hyperandrogenism from a regular lab. So other disorders, of course, need to be ruled out. So you may do testosterone, not much for the definition or to diagnose hyperandrogenism, but also to rule out other causes, which to exclude the differentials, which we all do for polycystic ovary. The other disorders with irregular menstruation and hyperandrogenism need to be excluded from the diagnostic criteria. Even in the absence of a definitive diagnosis and the lack of approved therapy for PCO in adolescents, treatment options that alleviate current symptoms and decrease risk for subsequent associated comorbidities are recommended. That is something of a different thing. I think the next talk will deal on that. And there's so much of prevalence of metabolic syndrome, even from a very early age. I think that is something which again needs special focus, which was in the scope of this talk. And although obesity, insulin resistance, and hyperinsulinemia are common features in adolescents, these features should not be used to diagnose PCO. So I think, again, we all understand that, and that is what we want to say. Thank you very much. I think I'll conclude here and stop sharing. Thank you. Sorry for the interruption and sorry for the break. Hi, Dr. Minu. Hello.
So good afternoon.
Hi, good. Hi, Uday. Hello. You can move on.
I think we can move on with Dr. Minu's talk now. If by the time Preeti gets hold of all the questions, Dr. Minu has been introduced, I think.
Yes, sir. So is my screen visible?
Yes, very, very well visible. Yes. Better if you put it on slideshow.
Yes, I'm just trying that.
Yes, we got it.
Okay, sir. Good afternoon, everybody. For today's talk, the topic given to me is adolescent PCOD, covering the guidelines. We do understand it affects 1 in 10 women. The prevalence worldwide has been, it is 3.4% of the women are affected worldwide. And again, PCO may also be found in a lot of women who otherwise ultrasonographic findings of PCO in 8 to 25% of the normal women as well. So when we move towards the guidelines, we just a overview that we started in 1990, the NIH criteria came forward. Then the most currently used criteria is still the Rotterdam's criteria, which was introduced in 2003. And 2 out of the 3 was the main criteria, which was, I'm sorry. Yeah. So which was oligoanovulation, clinical and biochemical hyperandrogenismia, and presence of a polycystic on ultrasound. Then came the AE-PCOS criteria in 2006, which said that the clinical and the biochemical signs of hyperandrogenism, along with ovarian dysfunction, including the oligoanovulation and or presence of PCO, was the main criteria for AE-PCOS criteria in 2006. And as discussed earlier by the earlier speakers, later on, the PCOS was also categorized into different phenotypes, which was A, B, C, and D. And because of this, because every PCOD would be behaving differently, so it was very important to categorize what kind of phenotype they were falling in. Now, in 2018, we had the International Evidence-Based Guideline for the Assessment and Management of PCO. And here, all the major, the ASRM, the ESHRE, the Monash University, CRE-PCOS, along with FOXI, these recommendations were set, and they were the baseline for how do we go about assessment and the management of the PCO patients. Again, I'm coming back to the topic, which was mainly the adolescent PCOD. The FOXI ICOG GCPR recommendations came in very recently, and we do follow this. And when you're coming to this particular guideline, I think this is the recent guidelines where Indian guidelines have, and all the Indian studies were taken into account. And according to this, we do understand that adolescent, as per the WHO, was any person who is between 10 to 19 years of age. And PCOS, with the pooled prevalence in Indian adolescent girls, was very high, was found to be 1 in 5. Another thing which is very important with this guideline was that adolescents who were at risk should be reassessed at 8 years post-menarche. This was a very important, good clinical practice point. And those adolescents who did not fit the criteria but had the following features, which was hirsutism, inflammatory acne vulgaris, which were not poorly responsive to topical therapies or oral antibiotics, or focal hirsutism, menstrual abnormalities, and significant weight gain, are those adolescents who were considered at risk. So this was a very important point which was added in this FOXI ICOG guideline. Now, coming to the risk assessment, again, the clinical symptoms and clinical characteristics were distinguished in this particular guideline, where they said the symptoms should be the ones which were labeled here, and the clinical characteristics, which was high BMI, dyslipidemia, and other parts were also given a lot of importance, where the risk factor was assessed. Now, coming to diagnostic criteria, especially for adolescent, as Dr. Basab sir has really very clearly mentioned in the previous talk, that you have to see the post-menarche. Any girl with 1 year post-menarche, more than 90 days for any one cycle, was one of the diagnostic criteria for PCO in the ovulation, ovulatory dysfunction. 1 to less than 3 years post-menarche, which was again less than 21 days or more than 45 days. Now, that was a criteria for the adolescents. Coming to the clinical hyperandrogenism, again, mild hirsutism, as clearly mentioned earlier also, was a part of puberty, but hirsutism and severe acne should be assessed in adolescents. Hirsutism with the modified Ferriman-Galway scoring, scores less than 4 indicate mild hirsutism and should not be really categorized as a PCOD, but 4 to 7 definitely were the ones which indicated moderate hirsutism, and more than 8 were severe hirsutism. And again, the IAA criteria is used for assessing the severity acne. Coming to the biochemical hyperandrogenism, one can use the total testosterone levels, free testosterone, and a calculated free androgen index should be used to assess the biochemical hyperandrogenism. Again, ultrasound is very clearly mentioned as a grade A recommendation in the guideline that it should used only for adults. A woman with less than gynecological age of less than 8 years, ultrasound should not be done at all. And especially in adolescents, more than the number of follicles, what is important that the ovarian volume is given significance. And if you're using trans-abdominal ultrasound for adolescent, then the threshold for PCOM would be an ovarian volume of more than 10 cc on either ovary. Now, coming to the lifestyle modification, it remains same for adolescents that yes, they need to adequately exercise at least 60 minutes of moderate to vigorous intensity physical activity is recommended for adolescents. It's a grade A recommendation. And for overweight women, 5 to 10% of weight loss or a calorie deficit of 30% or 500 to 750 kilocalories per day in an overweight women. Now, coming to just overview of the pharmacotherapy, even for adolescents, combined occipitals can be given. All preparations are equally effective, but one should use the lowest effective dose. And between 12 to 16 years of age, it's a grade C recommendation, but low dose COC only to be used and for the shortest period of time, maybe up to 7 days. And after 16 years in symptomatic girls, low dose COC to be used. Again, when it comes to metformin, it could be given to adolescent with a BMI of more than 25 for the management of weight and metabolic outcomes. And apart from this, all the other anti-obesity or anti-androgen, one has to get the treatment line in concurrence with the endocrinologist. That is a grade B recommendation by the guidelines. Again, lifestyle modifications, as we said, and a low dose COC and all the other parameters with hirsutism, acne, alopecia. Again, if it is very symptomatic for adolescents, it can be used. They should be treated, but in concurrence with the endocrinologist. So the main two guidelines, I think the recent ones that we are focusing is on the International Evidence-Based Guideline for 2018 and our current 2022 guideline by FOXY ICOG. Thank you.
Thank you, Meenu. It was indeed in-depth, vastly covered. All the questions can be addressed in the, they will be answered over there. Let's move on to the next session, Preeti.
Yeah. So I take the pleasure of starting the next session. For the next session, we have Dr. Mandakini Meg Madam and Dr. Durga Das as a chairperson. Nilima, please put the CV. Dr. Mandakini Meg Madam has been the chairperson of ICOG in 2020-21. She is right now the president of EMWI Central Council, also the international vice president of MWIA Central Asia, and she has been the national.
Preeti, it's okay, Preeti. Everybody knows me at ICOG.
Everybody knows, madam. And Dr.
Especially.
Durga, and we have with us also Dr. Durga Das, who has been the governing council member of ICOG in the past as well as now in the present, chairperson of the Public Awareness Committee in the past, and the national coordinator of multiple FOXY CMEs in the past. We can please request our both our chairpersons to introduce the next session speakers.
Yeah.
The first speaker is Dr. Rakhi Singh.
Yeah. So good afternoon, everyone. I think good evening, and I think it's a pleasure, Rakhi, to be here on this platform. If you remember, when I was the ICOG chairperson, you were the person who came forward with that certificate course. I said, Madam, I'm going to do it, and we were the, I think, almost the pioneer in making these certificate courses very, very successful. So I'm extremely happy as a past ICOG chairperson. The persons who has done so many courses already with me, they are now repeating, and Sarita, Parag Binniwale, everyone is taking it to the very higher level which we have started. We could do only 11 courses, but now day in and out. And then attendance is also so much increased, Raki. In our days, of course, it was COVID that time, but now, though there is no COVID, but you can see the interesting component, your scientific content, everything is wonderful. And I will welcome Dr. Durga Shankar Das, my co-chairperson, also on this course. And the first speaker of this second session is, can you display the Raki herself is going to talk on her subject. And I want to introduce Raki. Raki, she was the president of Noida OBGY Society. I have been visiting, I have given orations there. And now she was the chairperson of endocrinology committee, Raki.
Yes.
And the stage is yours, Raki, and kindly give your beautiful speech and, enthrall us with your speech.
Thank you.
Raki, huh?
At the outset, I thank ICOG Dr. Parag sir and Dr. Sarita ma'am for giving me this opportunity to do this. And as we all know, my topic is on androgen excess, a cosmetic concern. And basically, we need to not only treat the fruits what we see just above, but we need to go to the root cause, which we've understood all this way. While the root cause of PCOS and hyperandrogenism is therefore the state of an excess production of male hormones through these hormones are normally found in the woman at a lower levels. The most clinically relevant hormone is the hyperandrogenism and the testosterone, which is converted peripherally to dihydrotestosterone, and it is biologically active form of the testosterone. Richard Archer and Thayer reported the association of hyperandrogenic symptoms with abnormality in the glucose metabolism, highlighting the presence of polycystic ovaries in these patients, and which we have learned all this while in the pathophysiology. And we also have learned about the diagnostic criteria associated with the PCOS. There are, which started from 1990 and till 2003 and 6. One thing which is very common in all of these diagnostic criteria, various different forms of guideline criterias, that is hyperandrogenism, which is the cause of PCOS. And the cosmetic concerns with hyperandrogenism, as we all know, there are various cosmetic concerns which are seen like hirsutism, the acne, alopecia, acanthosis nigricans, which are very visible and they speak volumes. And the first lady with the beard was appeared in 1800 in the history. And then there are stubborn acne which are present all through on the female. As we all know, the hirsutism is the most consistent and reliable symptom using for the evaluation of clinical hyperandrogenism. It is present in about 60 to 80% of the PCO patients. Acne is the second most common sign of hyperandrogenism, and which is present in 10 to 34%. Whereas androgenic alopecia, or the male pattern of baldness, is another symptom of hyperandrogenic condition occurring in the PCO woman with around 3 to 34%. And the prevalence of hirsutism, which we all know with the hyperandrogenism, is seen. And the maximum what we see in these patients is hirsutism, then followed by the acne, the female pattern of hair loss, alopecia, acanthosis nigricans, seborrhea, and striae as it is. And these patients, all of them with hyperandrogenism being there, they have lot of tendency towards depression, anxiety, eating disorders, psychosexual dysfunctions, negative body image, and a reduced quality of life. And there are a lot of hormonal abnormalities, symptoms of these diseases. Later on in the life, these females do have fertility issues and these treatment for all these problems which follows through. And there are various investigations which have to be done for these patients. And do remember to take and evaluate a in-depth history for these patients for the onset of the duration, the irregular menstruation if the patient is having, and if the hair loss is there, or hirsutism is there, or if there is acne, how long is that duration, whether it has happened immediately, it is started very fast, or it is just a slow over the period of time the patient has had. And the symptoms speak volumes. Seeing the patient itself, we come to know that the patient is having all these acne, hirsutism, seborrhea, acanthosis, which is the scaly skin over the back of the nape of the neck. And we do need to understand and take a detailed history about the drug intake if the patient is taking any medications like corticosteroids and any medication with lithium, vitamin B12, thyroid hormones, halogen compounds like iodine, fluoride, chlorides, antibiotics like tetracycline, anti-tubercular drugs, or anti-epileptic drugs. They also play a major role. And we have got the posters for the algorithm for the treatment of acne and hirsutism uploaded on the Foxy website, from where you can download it. And acne, when we talk about, it is a term called as acne vulgaris, which is a disease involving pubaceous unit that presents with non-inflammatory lesions like open or the closed comedones, which can be the inflammatory lesions like papules, pustules, or nodules, and varying degree of scarring is seen. And acne is associated with broad range of potential harms, including the symptomatic discomfort, scarring, emotional stress, psychological distress, occupational impact, and the potential psychological interference as depression, and leading also to suicide for many of these patients. According to the Indian Acne Association, the acne can be divided into 4 types. That is mild, moderate, moderately severe, and the severe. Mild is just an open and closed comedones with few of the inflammatory papules and pustules. Moderate acne has papules and pustules predominantly over the face, and the moderately severe would have inflamed nodules on the chest and the back also. And severe are very large painful pustules and nodules, which would be seen over the face, forehead, the back, and all the other parts. Management, when we talk about, it is basically the counseling for the dietary modification for these patients, discuss the treatment options and the side effects with these patients, and do inquire about the planning for the pregnancy if this patient is doing. And if she is planning for the pregnancy, she needs to postpone that. And on ultrasound, if there is, we need to note that whether the ultrasound features of morphology for the ultrasound for PCO is present or not. We come to know whether the also note for the normal anti-androgen levels, that is testosterone levels, also for these patients. General and cosmetic skincare, washing of the face repeatedly has to be advised. The tropical therapy has to be advised, or oral antibiotic has to be given, like or oral isotericin. If the patient is taking, then we need to avoid for the pregnancy. Or the combined OC pills for the moderate or moderately severe or severe acne has to be advised. And if the clinical or the biochemical androgen excess and or the PCOM on ultrasound is seen, then general and the cosmetic skincare allow for all these patients, and the topical therapy along with combined OC pills for the patients for the duration of 3 to 6 cycles have to be given. If there is no improvement with the 3 to 6 cycles of the treatment, in consultation with the dermatologist or the endocrinologist, add little amount of spironolactone or cyproterone acetate, but these patients should be advised to avoid pregnancy. And when we talk about the different types of acne and the treatment, in the mild acne, the patient can be advised for benzyl peroxidase local application or the application with adapalene, and the topical antibiotics like 2% erythrocin along with clindamycin the patient can take. In moderate acne, topical benzoyl peroxide along with doxycycline for 5 to 10, 50 to 100 milligram daily, or azithromycin 500 milligram once daily for 3 days can be given. And for the along with oral contraceptive pills. In severe acne, the patient should be referred to the dermatologist, and along with combined OC pills, antibiotic can be given for these patients. The local application, the local treatment with the chemical peels, laser, microneedling, or the platelet-rich plasma can be advised for these patients, which are the fruits what we are treating. But the above all treatment which we are giving the treatment for the roots, the grassroots level. When we talk about the hirsutism is well known with this beard lady, which appeared in circus shows in around 1800 years back. And today, with at that time, with the excess body and the facial hair, which was not known. And today we know that it is a polycystic ovary syndrome, what she had. And for this evaluation, there is modified fragment Galway score, which has a scoring system from 0 to 36. And if the score is up to 15, then it is mild. 16 to 25 is moderate. And any score more than 25 indicates that it is severe hirsutism. We need to evaluate for the induced changes if there are any drugs which this patient is taking. We need to consider and ask this patient to stop these drugs so that the biochemical signs of hyperandrogenism and virilization can be stopped. If hyperandrogenism and virilization is of slow onset and regular periods, then it could be the idiopathic hyperandrogenism or non-classical adrenal hyperplasia. We need to know that by giving the test, we need to ask the test of 17-OH progesterone. And if the results are more than 200 with ACTH test, we also know to rule out the congenital adrenal hyperplasia in these patients. Hyperandrogenism and virilization, if it is a slow onset of hirsutism, in these patients, the polycystic ovarian disease could be one of the cause, and clinical or biochemical hyperandrogenism along with oligoovulation and PCO morphology on ultrasound, then we know it is there. When there is a virilization and rapid onset, then androgen secreting tumors could be the cause. And if there are no signs of hyperandrogenism or virilization, it could be the idiopathic hirsutism, what we are looking at. The management first per se would be the lifestyle modification for these patients, and for the obese patient also, that lifestyle modification is the mainstay. And the first line of treatment, no OC pills combination is recommended over the other, as Meenu has rightly said. For obese patients for more than 39 years of age, use of ultra low dose 20 microgram of ethinyl estradiol based oral contraceptive pills, and it can be used for the minimum therapy of 6 months. And other local applications of the direct peel methods, the local application for the hair removal can be used. And when we talk about the second line of management, anti-androgen therapy, if hirsutism persists despite 6 months of the treatment with OC pills, then anti-androgen therapy is recommended with flutamide having a potential for the hepatotoxicity, and minimum duration for the therapy is for 6 months. And here also we need to avoid for the pregnancy. And combined OC pills, when we talk about, it improves the menstrual irregularities, improves hyperandrogenemia, lowers the strength, low dose of estrogen with progesterone with anti-androgens are better. Other anti-androgens like drosperinone, Dynogest or Norgestimate are the good ones. And when we talk about the adolescents less than 16 years of age, progesterone alone is the best one to be used. Metformin, a word about metformin is PCOS with a BMI more than 25, non-obese PCO with insulin resistance. Metformin can be used in these patients up to the dosage of 1,500 to 2,000 milligram per day. A combined OC pills treatment for hirsutism, we have anti-androgens like drosperinone, cyproterone acetate, and the hyperandrogenism, anti-androgenic OC pills like levonorgestrel have a higher potency. And anti-androgens for the treatment of hirsutism like spironolactone can be added with or fenestride or flutamide. Spironolactone can be added to the dosage of 100 milligram per day in divided doses twice daily. Drosperinone is the progesterone derived from 17-alpha spironolactone, which works wonders for these hyperandrogenic patients. And a pill contains progesterone with low anti-androgenic activity is better choice in the treatment for PCOS because estrogen component of these pills increase the level of sex hormone binding globulin and which acts better. And these anti-androgens can be added for these adolescents also, where the OC pills we are not planning to give, and she is having a moderate to severe hirsutism. Spironolactone can be given with a starting dose of 25 milligram. Normally, we don't go beyond 100 milligram of spironolactone. Cyproterone acetate or the flutamide can be given. And normalize the menstrual cycle and the endocrine metabolic variables can be given. To conclude, a basic history, a detailed history of these patients have to be taken of the irregularity in the cycles, the hirsutism, the onset, and any medication the patient is taking, and the clinical evaluation of acne, hirsutism, acanthosis has to be understood. And there are these two posters with the algorithmic approach being present in the Foxy website, which was done when I was the endocrine committee chairperson, which is available at Foxy website. And these are the references from where the talk has been made. Thank you all. And do remember, all these adolescents are very much keen about their body image. So do take them seriously, and they have to be addressed because they have a lot of anxiety and issues with their depression and anxiety, which has to be taken very seriously. Thank you all.
Thank you, madam, for a lovely presentation. Can I please request Dr. Das to introduce the next speaker?
Most welcome, Chaitanya. Chaitanya is one of our most vibrant incumbent chairperson, and he is also the convener, and he is the organizing secretary for the coming ICOJ National Conference in Pune. So hope all of us are waiting for a good feast from him. He's a very dynamic and versatile chairperson. So let us listen from him.
Good evening, everyone, and thank you, Durga Shankar Das sir, for that kind introduction. At the outset, I would like to thank the ICOG chairman, Dr. Parag Biniwale, and Dr. Sarita Bhalerao for giving me this opportunity to be here, and my mentor, Dr. Rakhi Singh, who is my co-convener as well, for giving me this opportunity to share my thoughts or views on. Can you see my screen?
Yeah. Yeah.
Okay. To share my, just a minute, huh?
Rakhi, I missed your.
Hello.
So it was excellent lecture. In between, I gone somewhere. So excellent lecture, Rakhi, and all the best for your future endeavor. And
Thank you.
welcome, Dr. Chaitan. My co-chairperson has introduced you already. So please go ahead with your presentation.
Thank you, madam. I'm just trying to put my, yes. Okay.
Yeah.
So thank you so much. And I am here to present my views on insulin resistance in obese and lean PCOS. Now, this is a 3-day course, certification course from ICOG on PCOS, and insulin resistance forms a very important aspect or part when we are discussing about PCOS. To begin with, I would like to express my gratitude and seek blessings from all my teachers, seniors, and colleagues who are here today. As we all know that PCOS presents to us in a very different or very dynamic clinical picture. It may present to us with just an ultrasound report showing polycystic ovaries. It could present to us in the form of fertility issues, or as discussed, androgen excess issues in the form of acne or hirsutism. Irregular menses is quite common. Obesity is one of the problems or issues which go hand in hand with PCOS, and acanthosis nigricans is one of the ways to present when there is presence of insulin resistance. So all in all, there are many various ways in which polycystic ovarian syndrome can present to us. And we all know that PCOS is basically divided into 4 different phenotypes: type A, type B, type C, and type D. We should know about these phenotypes because the insulin resistance varies depending upon these different types of these different phenotypes. Type A, it has got hyperandrogenism, chronic anovulation, and polycystic ovaries as a component of it. Type B, hyperandrogenism is present along with chronic anovulation. In type C, it is the hyperandrogenism along with the polycystic ovaries, which marks the type C phenotype. And type D is chronic anovulation and polycystic ovaries. However, of all, hyperandrogenemia is one of the hallmarks for polycystic ovarian syndrome. There are various ways by which you can define polycystic ovaries. There are different organizations which have come up with their own definitions, like NICHD came with their own definition, Rotterdam criteria, and then the Androgen Access PCOS Society came with their own criteria in 2009. However, all of us have been using Rotterdam criteria most of the times, and that's the standard protocol or standard way of defining polycystic ovaries, wherein we need to have 2 of the 3 criteria present to label or define her as having polycystic ovarian syndrome. That is presence of clinical hyperandrogenism, presence of oligomenorrhea or oligoovulation, and presence of polycystic ovarian appearing morphology on ultrasound. So 2 of these 3 criteria should be present to diagnose her as having PCOS. What is the Indian context?
Chaitanya,
Prevalence of PCOS. Yeah. Hello.
your slides are not visible. There is some timer which has come up.
Since when? Since the beginning?
Just now,
Just
since
now?
explaining, just
Now?
it's not come. Some timer is there. Zoom app update is required once. Stop it and restart it.
Now?
Not yet started slide share.
Yeah. It's visible now?
Nothing.
Then I don't know.
You send across so that
There's nothing visible on my end, actually.
nahi, this slide share is not started.
Yeah, reshare, sir, once again.
Okay, let me do that. One second. Now?
Yeah, your screen has opened up. Desktop.
Oh, not the.
Not the presentation.
Let me check. Now?
Yes, sir.
Good to go.
Yeah.
Visible? Okay,
Yeah.
thank you. Sorry for that inconvenience. Okay, so in Indian context, prevalence of PCOS in India is close to 12%. The prevalence of infertility in women with PCOS in India is around 80 to 85%. Indian women with PCOS have a higher degree of hirsutism, infertility, and acne. They experience lower birth rates following IVF. However, the important thing what is to be noted is Indian women have high prevalence of insulin resistance and metabolic syndrome compared to BMI matched PCOS women of other ethnic groups. And that's the reason why it's important for us to understand this important aspect of insulin resistance. What do we know till date about PCOS? As I discussed, hyperandrogenemia is the biochemical hallmark of PCOS, and insulin resistance is the essential pathophysiologic mechanism in the development of all metabolic complications of PCOS. So if I have to understand the metabolic complications, I have to understand the insulin resistance, how it works, and what can I do about this insulin resistance. And the metabolic syndrome is a cluster of conditions that occur together, increasing the risk of heart disease, type 2 diabetes, and stroke. Now, I have been discussing about this insulin resistance and PCOS, but the question which always comes up in my mind is PCOS responsible for insulin resistance, or insulin resistance is responsible for polycystic ovarian syndrome? Well, the answer to this question is not very straightforward, and that's the reason why we keep on discussing about this insulin resistance with every PCOS talk, every PCOS webinar, seminar, or workshop. I'm going to go through the definition of insulin and resistance. What is its prevalence in PCOS related to obese PCOS and lean PCOS? What is the role in the pathogenesis of PCOS, role in the different complications of PCOS? What are the tests that are needed or can be done for diagnosing insulin resistance, management of insulin resistance, and lastly, a slide on what are the latest guidelines. Insulin is a small peptide receptor binding hormone which is released by the pancreatic beta cells, which binds to the cell surface receptors. The pancreas produces the insulin to help regulate the blood sugar levels, and insulin allows the body to use glucose for energy. Insulin resistance, on the other hand, is identified as the impaired biological response of the target tissues to the insulin stimulation. All tissues with insulin receptors can become insulin resistant, but the tissues that primarily drive the insulin resistance are the liver, skeletal muscles, and the adipose tissues. Skeletal muscle is one of the very important part which leads to insulin resistance, or whatever the impact of insulin resistance is there is majority of the times because of the skeletal muscle, because of the sheer size of the skeletal muscle which one has. Insulin resistance impairs the glucose disposal, resulting in a compensatory increase in beta cell insulin production and hyperinsulinemia. Insulin resistance is independent of obesity, but it is amplified by obesity. So it does not mean that a lean PCOS woman will not have insulin resistance. She can also have insulin resistance. However, if there is presence of obesity, in addition to PCOS, it will amplify the insulin resistance. What is the prevalence of insulin resistance in PCOS? It is estimated to be between 50 and 90% of women with PCOS. Approximately 80 to 95% of women who are obese and has PCO will show insulin resistance, as against 75% of lean PCOS women will show in prevalence of insulin resistance. So little bit increase in insulin resistance with the increase in the weight and obesity. Insulin resistance is present in all phenotypes, and it varies according to the PCOS phenotype. However, it is most commonly seen in women with type A, that is, who has got hyperandrogenism, who has got oligoovulation, and who has got polycystic ovaries. All the three features are classically present. That woman is going to have more prevalence of insulin resistance as compared to type C and type D. Type A and B, 80% of them will have IR. Up to 65% of women with type C will have insulin resistance, and up to 38% of women with type D will have insulin resistance. What are the implications of this insulin resistance? In the first place, what insulin resistance does is it leads to increased secretion of insulin by the beta cells, leading to hyperinsulinemia. Now, this hyperinsulinemia then has an effect on the different organs of the body, majorly the hypothalamus, the liver, and the ovary. So what it does in the hypothalamus, it increases the GnRH pulse frequency and amplitude, which leads to increase in the LH pulse frequency and amplitude. This increased LH will act on the theca cells of the ovary and will lead to increased production of androgens. That is one of the reasons why women with insulin resistance also have hyperandrogenemia. In liver, it decreases the hepatic protein production, leading to decrease in the SHBG. So on one hand, there is increase in the production of androgens. On the other hand, there is decrease in the SHBG. Therefore, there is increase in the circulating levels of free androgens. In adrenals, it leads to increased CRH secretion, again, there is an increase in the androgen production of androgens as well. On the other hand, what it does in the ovary is it acts through the IGF-1 receptors. It decreases the IGF binding protein 1 and increases the IGF-1. Now, the most important thing what we all have to understand here is that there is selective insulin resistance. What do I mean by selective insulin resistance is insulin resistance is seen only in the peripheral tissues. Ovary remains sensitive to the effects of insulin. So let me go back one slide, and here let's understand what insulin does. After binding to the insulin receptors, there are various pathways that are activated post receptor transcription, leading to glycogenesis, protein synthesis, steroidogenesis, and mitogenic action, of which glycogenesis and protein synthesis mostly takes place, as I said, in the skeletal muscle, while the mitogenic action is the one which is predominant in the ovary. So what it does, it selectively inhibits, because insulin resistance is seen in the peripheral tissues like the skeletal muscle, wherein the metabolic activity is more commonly seen as a result of insulin action, as against the mitogenic activity of insulin, which is predominantly seen in the ovary, is not affected. So the metabolic issues persist, while the mitogenic actions of insulin are still going on. PCOS is associated with insulin resistance and hyperinsulinemia that are exacerbated by obesity. All these effects which I just talked about regarding hyperinsulinemia are exacerbated by ovary. Now, what it does to lipid profile? IR in adipocytes. So, second commonest site at which it is acting is the adipocytes after skeletal muscles. IR in adipocytes lead to increased shunting of free fatty acids from fat tissue to the liver. These free fatty acids then induce hepatic synthesis of VLDL, resulting in elevated triglycerides and apolipoprotein and decrease in LDL, HDL. So all this leads to atherogenic dyslipidemia. What does obesity do in addition to hyperinsulinemia? Hyperinsulinemia leads to hyperandrogenism that leads to central obesity. So this is connected to each other, and that is how the things are. Hyperinsulinemia leads to potentiation of sympathetic outflow, leading to the potentiation of renin-angiotensin system, and it leads to hypertension. So there is an concomitant endothelial dysfunction as well. So hyperinsulinemia is also associated with hypertensive disorders. So all in all, this hyperinsulinemia and insulin resistance is contributing to the development of all the symptoms and signs of metabolic disorders or metabolic syndrome. However, they are connected to PCOS. The root cause of IR in PCOS is largely unknown. Improving insulin sensitivity in PCOS improves the reproductive, hyperandrogenic, and the metabolic features. Weight gain with worsening of insulin resistance in PCOS worsens the PCOS features. Hyperinsulinemia has got a genetic component in PCOS, and some insulin receptor gene variants are significantly associated with IR in women with PCOS. So in nutshell, I can say that because of this insulin resistance and hyperinsulinemia, there is reproductive failure, there are metabolic abnormalities, and there is also presence of androgen overload. It leads to dyslipidemia. In liver, it increases free testosterone. There is dysglycemia. In the pituitary and the ovary and the adrenals, they all lead to increase in the androgen levels, leading to PCOS. What about lean versus obese PCOS? Well, hormonal profiles are similar with respect to LH to FSH ratio, serum LH, progesterone, and testosterone levels. Both have insulin resistance and hyperinsulinemia with a prevalence of 83.3% and 93.1% in lean and overweight respectively. So little increase in obese women, no difference between lean and obese on pelvic ultrasound features. Hormonal and metabolic imbalances are more frequently encountered in obese PCOS women. Android obesity, high triglycerides, and high cholesterol levels are the only parameters that vary between obese and lean, being higher in women who are obese. These are the salient differences between obese and lean PCOS. I will not go into the depth. What are the consequences of this insulin resistance? Women with PCOS and IR have a significantly increased risk of adverse pregnancy outcomes, miscarriages, gestational diabetes mellitus, chronic diseases like type 2 diabetes mellitus, cardiovascular disease, metabolic syndrome, and mental health as well. So it is not just the PCOS which is responsible or which is found in women with IR. It also continues beyond pregnancy as well. IR is worsened by obesity, gut microbiota imbalance, vitamin D deficiency, sleep disturbances, diet with high AEGE, that means advanced glycation end products. This is one of the junk foods. Deep fried and roasted food are high in these AGEs. Endocrine disruptors like bisphenol, which is commonly found in the water bottles, the plastic bottles, and the chronic stress, which release cortisol. Insulin resistance is seen clinically in the form of acanthosis nigricans, skin tags, or with central obesity when the abdominal circumference is more than 34 inches. So these are the clinical features of insulin resistance. What testing can be done to diagnose IR? I can do fasting insulin, oral glucose tolerance test, glucose to insulin ratio. HOMA-IR index is currently the best and most widely validated marker, but the cutoff point for the diagnosis of PCOS-IR is still not universally accepted. Then there is quantitative insulin sensitivity test index, hyperinsulinemic euglycemic glucose clamp technique, and along with this, the clinical markers which we just discussed, like waist circumference, waist to hip ratio, wrist circumference, and presence of acanthosis nigricans. However, the most common and the simple test to check for presence of IR is the oral glucose challenge test. Empty stomach, give 75 grams of glucose and do the blood test, blood sugar levels 2 hours after giving 75 grams of glucose. And that's when we see it's normal. Fasting, when it is less than 100 to 125, it's in impaired glucose tolerance. If it is more than 126, we call it as diabetes. 2 hours has to be less than 140 to be normal, 140 to 200 IGT, and more than 200 as diabetes. How do I treat insulin resistance? Well, we start with the lifestyle modifications, nutritional interventions, physical activity, and then medications to improve the insulin response. Lifestyle modification, diet and exercise are the important components of this healthy lifestyle. It is recommended that women with PCOS should lose anywhere between 5 to 10% of their body weight in the first year after diagnosis of improved clinical outcomes. This is, in a nutshell, the components of a heavy diet. Fat should comprise 25 to 30%, carbohydrates 40%, protein 25 to 30%, and fiber about 25 to 30 grams per day. So this is an ideal diet which should be recommended for a woman who has got insulin resistance. The lifestyle changes, what it does, regular exercise and healthier eating will decrease the weight, decrease in the weight circumference, leading to decreased hyperinsulinemia, decrease in hyperandrogenism, hormonal balance is achieved, and ovulation occurs at the end. Lastly, what are the medical components that can be used to treat insulin resistance? Insulin sensitizers like metformin improves insulin sensitivity in women with PCOS. It decreases fasting insulin levels in non-obese women. Use of metformin for lowering insulin resistance is not recommended in normoglycemic women. So before starting metformin or any insulin sensitizer, we should test her for presence of IR, and if she has got IR, then we should be treating her with insulin sensitizers. Women with IGT can be prescribed metformin to prevent progression to type 2 diabetes. Metformin is used in the incremental dose of 500 to 1500 milligrams per day. It also helps in weight loss when combined with lifestyle modifications. Ionositol is another way of treating insulin resistance. It has got two isomers, myoinositol and decairoinositol. They have insulin mimetic properties. It acts as mediators of insulin action. DCI reduces the basal insulin levels, improves lipid profile, and reduces systolic blood pressure. It is given in a dose ranging from 1 to 4 gram per day, and if given in combination, the ratio between myoinositol and D-chiro-inositol should be maintained at 40:1. These are the guidelines which have been published by FOXY PCOS GCPR, wherein we have these evidence-based guidelines. And recently, we have come up with EEBR 2025, wherein we say that insulin resistance is common in women with PCOS, irrespective of age and BMI, which is manifested as an increased risk of impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes mellitus. Clinically, one must look for signs of acanthosis nigricans and truncal obesity. Insulin levels should not be due to assay variability and inaccuracy. Glycemic status should be assessed at diagnosis of PCOS in all adults and adolescents and should be reassessed every 1 to 3 years based on additional individual risk factors for diabetes. These are the guidelines which have now recently come up. We had published it in AISOG 2025. These are my references from where I have taken all the literature, what I just presented. In all, insulin resistance, a little difficult topic to understand, more theoretical, but has got clinical implications a lot. And therefore, we need to understand insulin resistance to a great extent. Thank you so much for your patient hearing.
Thank you, Chaitanya. And it's a very focused discussion because when people hear the word hyperandrogenemia, insulin resistance, they get scared. And what I find at Chaitanya, we are very nicely focused to differentiate. I like to give one or two instances,
Yes,
the particular words that obesity per se is not caused of PCOS, but you have very nicely pointed out the centripetal obesity. Now, second one-line sentence, very key and entertaining words. Metabolism is altered, but the mitosis is maintained. So you have made clarified things, these complexities in a very focused way, and people little bit who have got acquaintances can very well perceive the discussion you made. And the take-home message is only 5% reduction of weight can make a significant difference. It's a perceivable thing. 5% weight reduction is not a very great effort. So ordinary efforts and lifestyle medications, one can come to that. There are enough things to be told. Anyway, that will be kept in the discussion. But I am very happy that you have very nicely clarified these confusions. Thank you.
Thank you. Thank you so much, sir.
Hello, Shobha.
Hi, yes. Can you hear me?
Hello, Shobha. Have you? We can see you on the screen.
Yeah. I'm here. I'm here.
Hello, Dr. Shobha has arrived. She is a very well-known figure in POXY, a stalwart so far as contraception discussion goes on. And anywhere you find any seminar, webinar, CMEs on contraception, she is omnipresent. Needless to mention, to describe much of her, she has served POXY as chairperson and incumbent governing council member. So many activities. She is a very household name, and we should have the patience of listening her versatile talk. Okay, Shobha, now you can go on.
Thank you. Thank you, Durgas, for having remained a strong, good friend and supporter for so
Madam, your voice is very low.
What makes it okay? But in this, it is okay. Is it better now? Is it better?
Little better.
Meanwhile, I will just like to take this opportunity to invite all of you for the ICOG 10th ICOG annual conference, which we are hosting in Pune on 1st and 2nd of March. We would like to welcome you all in Pune. Thank you so much.
Of course, Chaitanya, don't take these few seconds. Take a good half an hour to present the conference. It deserves it. And we are eagerly waiting
It's not
for.
audible at all.
Madam, your voice is breaking.
Now,
Hey,
Chaitanya,
I don't know
we
why
can
that.
hear you
Now,
very well,
is it
but
better?
to
Yeah,
Shobha, we cannot hear.
yeah, some issue with her mic.
Is it better now?
A bit better.
Okay, then I'll have to connect with the phone.
Yeah, maybe.
Some problem with the microphone in the computer. So I will connect on the phone. I will speak. So give me a minute to connect on the
Sure, ma'am.
phone. I'm so sorry. You can't access it.
So, am I audible now?
Now, very well audible. Now you can go on.
Okay. So I'll share my slides on the laptop. But I will keep my audio and video closed here. Yeah. So with that, I am sharing my slides. Is my screen visible? That is important.
Invisible. The slides are not being shared.
I will share now. I'm sharing now.
It's too big for me. No, it's fine.
Now is it seen? My screen is seen?
Yes, visible.
Yeah. So let me begin by saying that it is an absolute privilege to be here, since it is the very first certification course of this year under the leadership of Dr. Sunita Tendulwarkar, the president, and Dr. Parag Beniwale and Dr. Sarita. And thank you so very much for making me part of this, Rakhi, Preeti, and Chaitanya. So my talk is about gut dysbiosis as a emerging cause of PCOS. Now this is an area still under research, but every day we find that there is new evidence coming up, and then this was something already stated by Hippocrates in 400 BC when he said that all disease begins in the gut. So it's possible that this enigmatic condition of PCOS also has its origins from the gut, and we need to understand first what we are talking about. So let us first understand that we do not exist as a single living entity. We have essentially one part human to one part microbe in our cell numbers, and this was established in 2016 by a very elaborate paper by Sender et al. And we have also understood that commensals are vital to health. The gut commensals digest fibers, vitamins are produced, they mature the immune system, they prevent pathogenic bacterial species from colonizing the gut. At birth, the gut is sterile, but it is quickly gets colonized by the birth canal environment. And then the adult microbiota, it has almost 1,000 different bacterial species. Some of them are bacteroids, example Prevotella, Firmicutes, example Clostridia, Enterococcus, and Lactobacillus. But then we need to understand it in terms of metagenomic sequencing. That is, these 1,000 different can get into 160 different species when you genomically classify them. And this is the collective microbiome, the microbiota, particular array of microorganisms unique to the individual. And just like our fingerprints are unique to us, even the microbiota is a fingerprint in the gut, which is unique to us. And possibly this is true for the vaginal microbiome also. So it is unique to each individual. It is also interesting to know that these bacteria exchange genetic material with one another, and this adds further complexity to the mix. Well, however, when we look at a connect to PCOS, we should understand that PCOS is a very common endocrine factor, especially for infertility, and it is associated with a low grade chronic inflammation, which causes ovarian dysfunction. And this is now evidenced that the visceral adipose tissue has an important role. So there is a direct connect between visceral adiposity and inflammation. Some dietary triggers can induce the oxidative stress, which causes inflammatory response stimulation, and inflammation can stimulate production of excessive androgen. from the ovary and from the adrenals, and this hyperandrogenism is associated with the low-grade chronic inflammation. So the abdominal adiposity is directly related to the inflammatory state. So this is something, which is depicted in this. The chronic inflammatory mediators like TNF-alpha, IL-1, IL-6, and CRP, etc., are seen to be raised in some women with PCOS. So inflammation and abnormal ovarian physiology, you can see that there is a link between obesity, the lifestyle, PCOS, and chronic inflammation, impacting the oocyte quality and impairing the ovulation. Now, there are inflammatory markers to be found. I will come to that in a short while. IL-6, IL-18, TNF-alpha, and CRP seem to be raised in women who have very florid phenotype of PCOS. And a study also showed that elevated plasma levels among PCOS women reflects a state of chronic inflammation with potential implication for insulin resistance independent of obesity. So it does look like insulin resistance and chronic inflammation are the two major pathogenic mechanisms for PCOS. So the research has shown that dysbiosis and inflammation are connected, and this bacterial flora, which you see on the left side, gets connected somehow with this plethora of the markers on the right side, like NFKB, TNF-alpha, and the interleukins, which you see. And there is also a change in the pH and lactate levels, and neutrophil chemotaxis also happens, etc., which becomes reduced, and the lactate gets reduced. All these impact the health of the gut endothelium. So the impact of gut microbiota on the reproductive tract and metabolic endocrine system is now, getting more and more acceptance. This was a paper published in 2020, and it easily, you can see the figurative explanation that the friendly bacteria will provide a kind of barrier, but then you can see the negative regulators, which are in blue, is the lipopolysaccharide, and that it finds entry into the circulation is what is going to cause the difficulty about the inflammation and the glucose homeostasis, and this will be lipid homeostasis will be disturbed, and this is going to cause insulin resistance, as we'll see in the future slides. But by and large, the other ones, like the short chain fatty acids and the branched chain amino acids, these are the positive regulators which are secreted by the friendly bacteria, and those are the ones which will decrease appetite, improve energy expenditure, improve insulin sensitivity, whereas the LPS, the lipopolysaccharides, are going to increase the insulin resistance by acting on all these tissues. So that is how it goes. And this was a paper which is very famous for its dogma hypothesis, dysbiosis of gut microbiota. That is the dogma hypothesis, a novel theory for development of PCOS. Now, we do understand the Rotterdam criteria. It has been brought forth by all the speakers today, and that is collaborating here. That is the incidence of PCOS for you. They are obese, they have menstrual dysfunction, they have small ovarian cysts. Yes. Now, the thought today is that there is a trigger, like a dietary trigger or an adipose tissue trigger for the chronic state of inflammation and insulin resistance. And this microbiological hypothesis is the dogma hypothesis. And it principally starts with a poor diet. And then there is a disturbance of flora, the dysbiosis of the gut microbiota. And there is an increase in the mucosal permeability, which is also termed as the leaky gut. And this allows the lipopolysaccharides from gram-negative colonic bacteria to the systemic circulation. But this does not actually result in any infection, which we might think. This actually leads to an activation of the immune system. These LPS activate the immune system, and they affect the insulin receptor function, and it drives up the serum insulin levels, hyperinsulinemia. Now, that will impact the ovarian microendocrine environment, increase ovarian androgen, and lead to anovulation. This is a figurative explanation of whatever I've spoken till now: the poor diet, the fast food, the malnutrition, as we call it, high sugar, high fat, low fiber. That causes the imbalance between the good and the gut bacteria. The dysbiosis of the colonic mycobacteria results in a leaky gut, and that causes the lipopolysaccharides to pass, and then that is what affects all the other tissues. Obesity also per se disturbs and causes the leaky gut, and then this insulin resistance, which happens, it drives testosterone production in ovary, impairs follicular development, causes anovulation, and the entire spectrum of PCOS. Now, this twofold etiology of PCOS by dogma states that there is already a disordered gonadotrophin secretion. Okay, that is the basis. That is the hereditary phenotype, etc., the genotype, etc., which you learned till now, which the LHFSH disorderly release from the pituitary, high free androgen levels, right, decreased SHBG, and then there is the compounding of insulin resistance and chronic low-grade inflammation. The state of insulin resistance can produce all three classical features. Just now, as Dr. Chaitanya said, increase in the antral follicle, impairing the ovulation, menstrual irregularity, and hyperandrogenism. Everything can be rooted in insulin resistance. So insulin resistance and inflammation responsible for later on the same factors are responsible for the metabolic syndrome, the diabetes, the cardiovascular disease. Okay, so that also is rooted in the emergence of insulin resistance. So our function as clinicians is to see that this insulin resistance somehow gets corrected, and the chronic low grade inflammation is also kind of corrected. So this slide is a little busy. I will not read the whole thing except to say that the leaky gut releasing the lipopolysaccharides causes what is known as a metabolic endotoxemia. And this metabolic endotoxemia is not an infective state. It is an endocrine abnormality, and it is triggered by the bad diet, as I said, because that reduces the bifidobacteria and the lactobacillus in the gut, which are the good bacteria. And the cell wall of gram-negative bacteria contains a very powerful immunostimulant, which is lipopolysaccharide, and which enters into the systemic circulation because of increased gut permeability, and which is again because of the disturbance in the gut bacteria, and the chronic activation of tissue macrophages impairs the insulin receptor function. So insulin receptors are situated on almost all tissues. They are very delicate in functioning and very easily affected by these influences like the macrophage affecting them, and that causes hyperinsulinemia, and which again blocks the follicular development. So the gut microbacteria impact on female reproductive tract has been postulated to the gut dysbiosis to have not only PCOS effect, but also impacts. Of course, infertility can also contribute to endometriosis, impair IVF outcomes, impair pregnancy outcomes when present in the gut and in the vaginal microbiome, and that dysbiosis, and that can also affect neonatal outcome in terms of growth restriction, etc. So let us now come back to the clinical question of PCOS, whether all this is relevant for the current treatments of PCOS. Traditionally, we do have the ideal initial approach of lifestyle modification, which is weight reduction, diet, exercise, decreasing principally energy intake, and with exercise, it is seen that is an improvement in insulin sensitivity, and there is ovulation. So all these factors of LSM principally improve insulin sensitivity, enhance insulin. That means they decrease the insulin resistance. The same has been thought about metformin, and the latest to the bandwagon is the pre and probiotics, which might also help in decreasing the insulin resistance. So the gut microbiome and its role in insulin resistance. So we already know that how hyperinsulinemia affects hyperandrogenism. There's good accumulative evidence now that gut microbiome can regulate the secretion of insulin. Then insulin increases activates tyrosine kinase, which in turn causes phosphorylation of the receptor and IRS, the substrate, and this stimulates the binding of lipid kinase and all these chemicals, which again causes phosphorylation of THR 308 and AKT, and then all these metabolic changes, biochemical changes lead to glucose utilization and uptake, and the synthesis of glycogen, lipids, and proteins. This is the normal functionality of the insulin binding to the insulin receptor, and that is how the glucose levels come down. But then it is thought that metabolites of bacteria, due to the gut microbiome dysbiosis, are involved in insulin resistance. They can disturb this function, and it has been seen that serum metabolome of insulin resistant individuals, those who are identified with insulin resistance, they show increased level of BCAAs, that is branched chain amino acids, which are associated with increased abundance of the species Prevotella copri and Bacteroides vulgaris. So this is the chemical which is seen in women with insulin resistance, and this can impact the functioning of the insulin receptors, and that means that it will increase insulin resistance. Okay, so there is another interesting interplay, and that is between metformin function and the microbiome. And Sun et al. Have investigated this, and they feel that gut microbiota play an important role in the mechanism of action of metformin, which can alter the gut microbiota composition and affect metabolic pathways. Metformin is capable of doing that, and gut microbiome profiles and gut-derived metabolites are related to host insulin sensitivity, which I have already been saying from the beginning of the talk. Now, metformin increases the short-chain fatty acid-producing microbiota. Now, this increased butyrate propionate involved in glucose homeostasis, and this can improve insulin resistance. So this is the micro detail of how metformin can increase. Okay, and this is still being researched. Maybe better and better explanations will emerge. Now, the species Bacteroides fragilis was decreased, and bile acid GUDCA was increased in the gut after metformin treatment. And this, with concomitant inhibition of intestinal FXR signaling, briefly, metformin improves metabolic dysfunction in part through the B fragilis GUDCA intestinal FXR axis. So this is what they have achieved through research. They have found that metformin can act by correction of the gut dysbiosis, which is present in PCOS. So we have one more reason for using metformin. Now, this group of people, Araco et al., reported that the microbial metabolite imidazole propionate also impairs the glucose lowering effect of metformin. So this is another microbial which, if present as a result of dysbiosis, can interfere with the action of metformin. So gut dysbiosis does matter. Overall, all these studies, they indicate that the microbiome and its metabolites are involved in the pathogenesis of insulin resistance. And these findings can also explain why individuals differ in their response to treatment with metformin. Because we often see that some women do quite well and others have no effect, and some others only moderately respond to metformin therapy. And situations like this, we must think about the gut dysbiosis and its correction. So this is further research on the female reproductive tract. I will not go into this. And I think I should quickly go on to the pro-inflammatory cytokine, so which we feel that even in lean PCOS individuals, there is an increase in pro-inflammatory serum TNF-alpha and IL-6. So it is not only leaky gut is not only obesity, it can happen in the lean PCOS also. And gut microbiota in lean women also can be responsible for insulin resistance. So probiotic and prebiotic have emerged as treatment modalities. All of you must be kind of coming across industry partners coming to you with these products. So remember that there is a WHO definition for a probiotic, which are live microorganisms, which if given in enough quantum can cause benefit to the host. They are microorganisms which benefit the host. But there are criteria needed to be met for a microorganism to be labeled as a probiotic. It must be resistant to gastric acid, to bile acid, should adhere sufficiently to the intestinal mucosa, not get excreted in the fecal material, and must convey benefit to the host. That means it should not cause disease and it should convey benefit. Common used probiotic organism, bifidobacteria, lactobacillus. And what is prebiotic? Now, this is a selective food source for good bacteria. First introduced by Gibson and Robert Ford, it's an alternative way of boosting the number of good bacteria. This is the prebiotic approach, and it is defined as a selectively fermented ingredient that allows specific changes both in composition and activity. the gastrointestinal microflora and confers benefit upon the host benefit. So symbiotic approach is what is thought to be appropriate for PCOS, pre plus probiotic, and target synergy being that pre will selectively stimulate the growth or activity of both the endogenous and exogenously applied the prebiotic beneficial bacteria. And advantages over a pure prebiotic approach is that host has a diet that has sufficient dietary fiber to support the optimal growth and function of the colonic microbiota. So a combination of pre and probiotic is going to give better result. So the potential for pre to drive down insulin levels of PCOS has been seen in animal studies, okay, which is statistically significant in that particular study. Now, to recap the pre and probiotic theory, they improve the intestinal barrier function. They reduce the colonic gram-negative bacterial load, which is the source of the LPS, the lipopolysaccharide. Reduction in transfer of the lipopolysaccharide across the mucosal wall. Reduction of metabolic endotoxemia, therefore, and they mediate the increase in production of GLP-1, which reduces the energy intake, which reduces appetite actually. GLP-1 also drops adipose tissue mass and a decrease in inflammation. It actually helps in reducing weight. This is a case control study. I'm finishing in another 1 or 2 minutes. A case control study of 39 PCOS patients and 40 healthy people, because I did not want to close before I mentioned the vaginal microbiota of PCOS. Along with gut microbiota, the vaginal microbiota also seem to be significantly different from that of healthy people, and it is characterized by increased diversity, increased relative abundance of mycoplasma and prevotella, and decreased relative abundance of L. crispatus. This suggests that vaginal dysbiosis, microbiome dysbiosis, will also participate or contribute to PCOS pathology, and therapies targeted at improving vaginal microbiota are promising. So this is the vaginal microbiome explanations. The other one which has emerged is the lactoferrin, which has got antimicrobial, anti-inflammatory properties. It is actually a macro nutrient. It is a protein, and it is an important constituent of innate immune system on cervical mucosa. But the antimicrobial activity of lactoferrin is because it has the ability to bind to free iron, which is an essential substrate for bacterial growth. It also causes bacterial lysis through its binding it binds to the lipopolysaccharide, does not allow it to cross into the circulation. It inhibits bacterial adhesion to the epithelial cells, and it inhibits the entry of harmful bacteria into host cells. It also promotes the growth of lactobacillus and bifidobacteria, which are the good bacteria, and can boost the immune system by release of cytokines. Therefore, consumption of lactoferrin can facilitate the immune system, may reduce the insulin resistance. So the symbiotic approach in PCOS would be to combine a pro and prebiotic treatment, perhaps. With this combination will increase the number of beneficial good bacteria in the colon. It is possible that with this, the leaky gut gets healed, and the short chain fatty acids will decrease the passage of lipopolysaccharides, and then the ovarian function may return to normal with this therapy. It will also increase the production of GLP-1 by the healthy colon mucosa, which reduce the food intake and results in decrease in body fat content. So these are the qualities of lactoferrin, which will not be for this particular webinar. I think dedicated one should follow that. The safety of pre and probiotic are generally accepted, and it is generally acceptable as non-risky. It has got a GRAS status, and in 2011, Elias published an article that probiotics do not appear to pose any safety concern even in pregnant and lactating women, and systemic absorption is rare when it is given vaginally. But bovine lactoferrin generally recognized as a safe substance by the FDA. So how to translate all this knowledge into practice? Apart from kind of the pre and probiotic, whatever is available for us for use, apart from the metformin which is available, or even the myoinositol which is available. The lifestyle questionnaire, lifestyle modification is still remains a very principal key intervention without which all other therapies will fail. So when women with PCOS come to us, girls come to us, we should have a healthy gut questionnaire in addition to everything else. We should ask them, do you have poor gut health? Do you have any of these symptoms? Regular upset, reflux, irritable bowel, sugar cravings, weight loss or gain without reason, poor sleep, constant fatigue, mental health issues, dry skin, sinus issues, respiratory, repeated infections, any autoimmune conditions, or food intolerances, or gallstones, hemorrhoids, or diverticulitis. So better to rule out all these conditions. And then we must also give them a tip on how to improve the gut health in addition to the other exercise and diet advice we give. We tell them to eat healthy food, of course, refined food to be avoided, refined carbs to be avoided, eat fiber, insoluble fiber, acts like a giant toothbrush, helping the digestive tract to keep everything moving along. So eat fiber to clean the gut of harmful, food. Include healthy fats, especially omega-3 fatty acids. Drink plenty of water to stay hydrated. Work on being less stressed. Okay, exercise and gravity helps food travel. So be erect, be walking, be exercising always. Include gut support nutrients such as aloe vera and probiotics to aid digestion. So let me end by saying what the Hippocrates said so many years back. Let your food be your medicine and your medicine be your food, and probably that will reduce gut dysbiosis and that will reduce the clinical manifestations of PCOS. Thank you very much for a patient listening. Thank you. Thank you.
Thank you, Shobha. We heard all the discussions. Now I think there will be Kumbh Mela around you. We heard terms like metabolic endotoxemia, lactobacillus, bifidobacteria, and all, let it be male or female persons, or particularly PT plus patients, those who are having little bit lipid disturbances, those who are having family history of diabetes, all will be now around you seeking your blessings. So I think you have, by virtue of this PCOS discussion, you have advised a panacea, that is prebiotic and probiotic. So ultimately, we got a very nice discussion. It's a panacea, and the cause of concern is metabolic endotoxemia. Okay, thank you.
Thank you.
Dear friends, I
Thank you very much.
on one thing, that ICOG national conference, which is there on 1st and 2nd, there's a workshop on PCOS per se, and another more detailed discussion, which you've not heard here, also to a certain extent would be discussed over there. So over to you, Preeti.
Yeah, thank you. Thank you, Dr. Rakhi. Yeah, I think that was very good. And I think all the four speakers were excellent. And the gut biology, the importance of micro and macronutrients is something that's really now catching up. And everybody is talking about it. All nutritionists, all even bariatric surgeons, everybody prefers to start giving us probiotics. And I think that was an excellent eye opener, Dr. Shubha, madam. So with this, we can now start with the panel discussion. Can I please request our moderator for today, Dr. Lakshmi Shikhande madam, to be this thing. Nilima, please put the slides. So Dr. Lakshmi Shikhande madam is from Nagpur. I think everybody knows madam is a receiver of number of awards, and she has been the national corresponding editor general for Jogi as well as for the AMWI India. She has been working very hard in ISOPAB right from last, I think, more than 9 or 10 years. She's also been the president of the Menopause Society and senior vice president of Foxy in the past. With Dr. Lakshmi, we also have two experts with us. That is Dr. Ramani Devi madam and Dr. Vinita Singh madam. Dr. Ramani Devi madam, we all know she's from Trichy. As you can see, the number of awards, I think the pages are a little less for the number of awards that Dr. Ramani Devi madam has received, and she's an excellent orator and a true academician. We also have Dr. Vinita Singh, Madam. She's from Patna, is right now at present the East Zone Coordinator of Foxy and the Governing Council member of ICOG with Foxy. Again, Madam has been an extremely good academician, has been working for all the levels of Foxy and has been the president of Patna Society in the past. And I think I would request now Dr. Lakshmi to invite all the panelists.
Preeti, you can invite. Preeti, invite all the panelists.
Okay, so we have Dr. Neelam Vise from Mumbai. She is a IVF consultant from Mumbai. Next, Neelam. We also have
Yes.
Dr. Sushma. Dr. Sushma has not been able to share her slide. Dr. G. Bhuvneet, senior consultant from Chennai and has been the joint secretary of Kanchipuram Society. We also have, this is getting cut, dear. When you are sharing now, it's getting cut. No, it's not seen. See, the names and all are getting cut. Is everybody able to see Dr. Niharika's name?
Yeah, we can see Bhuvneshwari slide.
Okay, Dr. G. Bhuvneshwari's slide is there. And
Yeah.
then we have Dr. Niharika Illu.
Yes.
You can go to the next one. Yeah. Dr. Niharika is a consultant from Visakhapatnam, executive member of the Vaginal Surgery Committee, and she is a member of the Prevention of Violence Against Women Cell. Next. We also have with us Dr. Apurva Asthana. Dr. Apurva is again a senior consultant gynec and is the joint secretary of the Greater Noida Obs and Gynec Society. Is a consultant basically from Noida and ART specialist and IVF consultant. Next. Dr. Vidya Lakshmi, she is again mainly into reproductive medicine and has been affiliated with the Indian Fertility Society as well as SR. She's from Coimbatore, has achieved a number of awards and co-authored a number of chapters even in the Foxy UNICEF guidebook.
Thank you, ma'am. Yeah. Good evening. And all the previous 7 talks were simply awesome with lot many take-home messages. And now here is the final session of the day 1 course of PCOS. My slide everyone can see?
Yes, ma'am.
Just a minute. Yeah, so straightway I am coming to the case. This is a case scenario, and it's a very much common case scenario in our day-to-day OPT where a 17-year-old girl has come to you. Her weight is 94 kg. She has come to you with irregular menses, hirsutism, acne, and she looks depressed. And this is an open panel, so anyone can answer any of the questions. So the very first question is she a case of PCOS?
Yes, ma'am.
Yes.
Yes, madam. Yes.
Yes. Because according to the new guidelines, you only need irregular menses and hyperandrogenism.
Clinical features of hyperandrogenism.
Yes. And you don't have to do the ultrasound, and there is no role of AMH as far as diagnosis of adolescent PCOS is concerned. And these guidelines have also defined what do we mean by irregular menstrual cycle. So we are not going to read the slide. Now, very, very practical question to all the panelists. How will you calculate her BMI? So her weight
by,
4 kg.
weight by height in meter square.
Yeah.
Weight by height.
So it is the BMI, yeah, weight in
By
kg.
height.
Yeah, I have given you the formula. So can anyone just calculate? So that each and every audience who have logged in, we are having almost 550 delegates who have logged in. It should be on tip of your you should be very, very easy to calculate the BMI. It's very easy. Her height is 5.5 feet. So in meter square, it is 1.67 meter. In meter square, 2.78. So 94 divided by 2.78, that is 33.8. Now, can anyone tell me in which category she fits? Normal weight, obese, morbidly obese, what? Overweight, what is the category?
According to Indian standards, her BMI is 33.8.
She'll be morbidly obese.
She will be morbidly obese.
Oh, she'll be
Morbidly
obese.
No, morbid.
Obese. More than 35 is morbidly obese. So here she is obese.
Yes, morbid obese. So you can see that Indian woman, the normal BMI is 18.5 to 24.9. Overweight is 25 to 30. Obese 30 to 35 and morbidly obese is 35. So our patient is in the category of obesity. So now naturally she is a case of obese PCOS. So how you will go about the weight loss? And all the are telling you the lifestyle intervention. So I want crystal clear take-home messages for the audience. Because what do we mean by lifestyle interventions? What are the interventions included in this? And then we will take diet and exercise separately. Yes.
Combined dietary and as well as dietary intervention with exercise. And we have to, it has to be, diet has to be prescribed according to the energy requirement as per the weight.
Coming to the
And
diet.
minimum of 30% reduction in the.
Vidya, just a minute. Let's go systematically. So now the lifestyle intervention has got two components, diet and exercise. There is no shortcut. There is no magical wand. Even if she wishes that you could, as a clinician, you should reduce her weight by 5 to 10 kgs instantly by some magic medicine. We don't have. So you have to give her a goal for weight loss. So what will be the goal? First, let us discuss the goal. Then let's go about how to achieve that goal.
5 to 10% reduction in the existing weight over 6 months.
5 to, yes, absolutely right. And your goal setting should be smart goal setting, that is specific, measurable, achievable, realistic and timely, which you all have said very, very loud and clear. Now let us come to the diet. Which diet plan is best? Let us go specific to the questions. So first, let us answer which diet plan you will advise. Internet is flooded with so many diet types. So which diet plan?
There is no standard diet
no
plan,
standard
criteria, but one diet plan is better than the other.
Correct.
It should be a healthy, tailor-made, and achievable diet plan.
More than that, sustainable, something that she will be able to do it on a long-term basis, because it shouldn't be like she does some plan and they can't stick to it and then again she gains back that weight.
So
she has to understand that it is a
yes.
long-term.
Apurva, please. Please go ahead. Apurva. So
long-term planning.
Yes, Bhuvneshwari.
The long-term planning and should be motivated to do that.
She has to be compliant according to her cultural thing, whether she is veg, non-veg, what is her daily routine, depending on all that.
As clinicians, we should actually more impress on balanced nutrition than particular diet like a keto diet or intermittent fasting. We have to explain the importance of a balanced nutrition to the patient when they are opting for a particular diet.
Ma'am, I think we should also counsel that this is something which is going to take some time, because most of the times patients, they expect some instant results. So I think we have to be very loud and clear about that. This is going to take a while to achieve and it's all right. And consistency is what is more important in all of this, whether it's exercise or diet.
So whether you
Lakshmi, shall I add one more important thing?
Yes, expert.
Yeah.
Yes,
See,
Ramani.
first thing is you just ask her the diet pattern, because the diet that is taken in the northern side and eastern side and southern side definitely varies. So you must plan a diet that can cut down 500 calories per day. Okay, that too based upon the BMI of the patient. That is very important. First, ask her to cut down the dairy products and high glycemic food. Plus, you have to tell her which sort of food she has to take and no sugary items. So that way you can tell her, take some 3 small meals, and then maybe if she can make it 2 larger meals, that is enough. That pattern is enough. And you have to have a limitation for carbohydrate, increase the protein, reduce the fat, and try to replace every meal pattern with fruits and vegetables as well as nuts. So we should tell her individually what she should take. That is the most important one. So that she reduces 500, cuts down 500 calories per day. And overall, at the end of 1 week, she may be able to cut down 2,500 to 3,000 calories. So this way, she can slowly reduce her diet pattern and try to reduce the BMI.
Absolutely right, Dr. Ramani. So I just want to ask my panelists, would you like to refer this patient to the nutritionist or would you counsel her on your own as far as diet is concerned? Just yes or no from all
Definitely
the
yes, definitely yes, so that they can have an individualized plan. Because this patient may probably need what she's taking, she may need a very focused attitude of how to go about it. So if you have the facility, definitely. But if you don't have the facility, then you are the best person to guide them, I guess.
But Niharika, there is other side of the patient referring to dietitian because they give you a lamba chauda, that diet chart, which no patient is able to follow in their day-to-day life. So I think
No, the dietitian also has to be good and you should already have a rapport with them and know what they're going to do it. You should know what they would have actually prescribed.
So don't feel guilty if you don't have facilities of dietitian or you are not able to refer or your patient is not willing to go. What Ramni has given you is very crisp manner. You can just tell her to cut down on the sweets and she can take a balanced diet. Anyway, she has to just reduce 1.5 to 2 kgs in a month, which is very, very easy. Don't tell her that you want to reduce 10 kgs or 20 kgs. So diet, now we will go forward. Now exercise. She is obese. So how much exercise will you recommend for a obese patient? Of course, she is morbidly obese. She has to be given for the moderate weight loss. So mild weight loss, the guidelines have given the recommendations. So can anybody simplify for the benefit of our delegates what you will actually tell her? What exercises,
Start with at least
how much,
20
what
minutes per day.
see? Yes.
Start with 10 to 20 minutes per day, mild to moderate intensity exercise for a more obese individual, then build on it. It should not be, according to the guideline, it cannot be 60 minutes of vigorous intensity exercise per day. It's very difficult for them. So gradually build up on the exercise and you have to concentrate more on the core muscles, core strengthening.
Ramni, I will come back to you after we discuss the exercise pattern for moderate weight loss.
Okay.
So this is what guidelines has given us, that if you want to do moderate weight loss, this is the amount of exercise they have to do. Of course, we cannot explain them being a clinician, what exercises, how much exercises. So it is better. Now we have got gyms mushroomed in each and every corner, in each and every street. So if you can motivate her to go to a gym rather than trying on her own, will be better. Now I am coming to my experts for their expert opinion as a clinician. What should we advise them as far as exercise is concerned? Yes, Ramni.
See, regarding the exercise, once again, it should be sustainable.
Yes.
1 day doing maximum work and the next 2 or 3 days not doing anything is not good. So ask them to start with 15 minutes per day in the morning as well as 15 minutes in the evening. Then they can slowly increase to 30 minutes. And preferably if the patient is quite young like this patient, maybe we can go ask her to go for a better aerobic exercise, which will try to reduce her weight rapidly. See, as you said, going to a gym is also a good suggestion because we can have a personal trainer who can instruct her along with the exercise and the diet pattern. So, but in general, at least 5 days in a week, she has to exercise for a minimum of 30 to 60 minutes. That will help her to sustain the weight. But if she wants to reduce the weight much more, maybe she has to take up a slightly larger number of minutes of walk, and it should be preferably a moderate activity, not a very severe gym exercise they don't need. That is also not good. So muscle strengthening, of course, very, very important, and cardiac exercise, both of them are very important to maintain for the obese girls to have a ideal muscle building of muscle mass. That is very essential.
Yes, and do tell them that there is no role of crash dieting. They should
Yes.
go for all those products which are being advertised on the internet, because there is no shortcut to the weight loss. They have to take a long cut, that is diet and exercise, and they have to imbibe it in their daily routine, because it's a lifelong commitment. They just can't do their diet pattern and exercise only for 6 months and then stop. She will be prone for rebound weight gain. So when you are counseling them, counsel them properly and do tell them that it's a lifelong commitment. Now, friends, we do have anti-obesity drugs. Now, newer drugs have come up, and now bariatric surgery has also been very, very common, very safe. So if your patient is morbidly obese, like she's 100 kg, 120 kg, she has come to you, she wants to have a child. So is there any role of anti-obesity drugs or bariatric surgery in case of morbidly obese patient? Any panelist can share their experience. Yes.
Definitely,
Definitely.
anti-obesity drugs like GLP agonists, the semaglutide, liraglutide have shown a lot of promise in obese PCOS cases. Nearly 70 to 80%. There are studies which have shown that it has caused significant weight reduction in women with PCOS, and they are also now considered to be very safe with fewer side effects.
Bariatric surgery, again, for morbidly, I think we can definitely advise, because they're doing lifestyle and exercise will not really change much in them. So we can definitely advise, and we do see a lot of pregnant patients post bariatric surgery now. And it also reduces, we have to emphasize, it also reduces their long-term complication risk, like diabetes and hypertension and dyslipidemia, cardiac risk is very reduced when they undergo this bariatric surgery. So you can definitely refer to a bariatric surgeon and ask them to look into it.
No, Ramni,
The BMI is more than 40.
very specific.
35 to 40. BMI 35 to 40.
More than
Definitely
40.
Obese I'm talking, because all these things you are not going to prescribe for obesity.
Obesity, yes.
Yes.
Not morbidly obese we are discussing, because we are really getting patients who are morbidly obese.
Morbidly obese.
They are coming to our OPD, they want to have a child, they are very keen to conceive, they want to conceive very fast. Ramni, my specific question, whether gynecologist can prescribe these drugs or we have to refer them to the endocrinologist. Specific query for the to the expert. Ramni?
You are muted.
Ramni, ma'am,
Before planning for this bariatric surgery on prescription for anti-obesity drugs, I think we have to have a complete metabolic profile that has to be worked out, and also the BMI. See, for example, bariatric surgery in very young girls like our patient, I don't think it is indicated. It
Not
is
in our
indicated.
patient.
Okay. In general, in patients who have already come to the reproductive age group, and then when they plan pregnancy, maybe we can advise them bariatric surgery only if they are not able to bring about the weight reduction over a period of 6 months to 12 months. Otherwise, don't do, because simply telling bariatric surgery, it is one of the most difficult things the patient will face after a bariatric surgery. Yes. See, and that too, if the woman wants to plan pregnancy, she has to wait for a period of 1.5 years to 2 years, almost everything gets normalized. And another thing is, the indication for bariatric surgery basically depends upon the metabolic problems the woman has got. If the patient has got a metabolic complication, even a BMI of 35 is an indication for bariatric surgery. But otherwise, in the absence of metabolic complications, up to 40 BMI, we can wait. But there is one category called a super obesity, where the BMI crosses beyond 50. And these are the candidates who really need a bariatric surgery. And of course, about the anti-obesity drugs, we have a lot of newer anti-obesity drugs that are coming up. But I think that in consultation with we can start prescribing them some nutraceuticals like that. See what we call it in Tamil, that vendayam, and that these seeds that can prevent the absorption of carbohydrates from the gut. But I think beyond that, this anti-obesity drugs, better we have a consultation with an endocrinologist under the...
Correct.
Because now we have to answer the law. So
Yes.
that is very important. So we have to be very careful in prescribing. anti-obesity. And before going for anti-obesity surgical management, we have to counsel the patient so much, because I've had few patients who were very much depressed because they are not able to have anything, food, anything that is restricted, and they are very much depressed. And I think now we have a sort of this balloon which can be inflated into the stomach, and temporarily it can reduce the weight. That is by preventing the absorption. Then once when the purpose is done, that is being taken off, not like the simple major complicated surgery like Re1Y anastomosis or partial gastrectomy.
Gastric banding.
Yes.
Madam, here I want to add points.
Purposefully, I have brought this slide because now there are so many newer drugs, and as I said, these surgeries are very safe. But it is in your interest that don't prescribe these newer drugs on your own. As Ramni has said, refer them to endocrinologists. Let them do the whole workup before prescribing these drugs. Again, they are not just a magic wand. They have got their own side effects, and you have to manage those side effects. Sometimes patient goes into depression because of these side effects, because of severe GIT upset. She is not able to eat. So it's entirely a different thing. But yes, drugs are available. And many patients they can see on Amazon. I don't know whether they can directly order on Amazon, or they are taking their drugs directly without any doctor's prescription. That also you have to inquire, because gone are the days when patient used to buy what we used to prescribe. Now all the medicines are freely available online, including these drugs. So this is the first term. And when you are referring, and when your patient is taking these drugs, she should not become pregnant.
Contraception.
Take care of.
Yeah.
I want to add, with your permission,
To avoid pregnancy for 1 year
Lakshmi
after the bariatric surgery. And again, you have to refer to a specialist doctor. Let that doctor decide whether she needs bariatric surgery, which bariatric surgery, what are the effects, side effects. Let them counsel your patients. But yes, you can give that these are the options. Yes, Ramni, you want to add anything?
No, nothing. I think everything is
Because,
covered.
we have to
Madam, one point I wanted to add.
Yes, Neelam.
When we are talking about diet and exercise, before we send our patient to exercise, it is very important that we do their vitamin D levels.
Yes.
Because they start rigorous exercise and sometimes they have bone fractures and everything. Another thing is, before going for the bariatric and anything, we can start. We have had a very good lecture on the probiotics.
Yes.
And third point, madam, which I would want to add is genetic history of the family. Genetic is not a genetic disease, but polygenic disease history of the family is also very important in these kind of morbidly obese patients, because they come with a family history of stroke, hypertension, diabetes in both parents, and they have most of the times folic acid metabolism problems. And we can add with high dose of active folic acid. Sometimes they with a probiotic, the metabolism starts boosting more with the diet and exercise and with these interventions.
Yes.
Point, Neelam. Any panelists want to add anything? So far, the lifestyle intervention is concerned, the diet, the exercise, the anti-obesity drugs, and bariatric surgery, because now we are moving to the management. Anybody wants to add anything to the lifestyle intervention component of our panel? No? So let us go to the management part. Whenever patient comes to you, she comes to you with immediate concerns. That is, she wants immediate solution. And then you have to educate and make her aware about the long-term issues, because our panel second component is prevention strategies. So our immediate concerns, you all will agree, is regularization of her menses, taking care of hirsutism, acne, and to make her lean, thin, because she is obese. Then long-term issues, insulin resistance. Just now we heard a lecture. Cardiovascular risk. Don't forget the sleep apnea and the malignancy risk. So regularization of her menses, just quickly. Can anybody answer how you will give, which OC pills you will give?
Ma'am, can I speak, please?
Yes, please, Neelam, please.
Ma'am, at this age, it is most important that we don't start OC pills for this young patients, we see a lot of prescription of continuous taking of oral contraceptive pills for 5 months, 6 months to 2 years. And what happens, these OC pills have estrogen and progesterone. The liver metabolism of these patients are, they have fatty livers, and it is rebound going to increase their PCOD. And that bleeding which happens is just a withdrawal bleeding. So the concept we can explain to the patient that even if they get 5 periods, 4 to 5 periods in a year is okay. And whenever they are missing the period more than 50 days, the simple thing is to take medroxyprogesterone acetate and get a withdrawal bleeding, which will avoid formation of the endometrial hyperplasia and polyps. And that way, a patient is not exposed to the external steroidal medication in the form of OC pills.
Yes, Neelam, you're absolutely right, because she is very young and we are concerned about her osteoporosis. And that is why we try to avoid OC pills, especially between 12 to 16 years of age group. But after 16 years, if it is really indicated, you can give low dose OC pills. But as Neelam has rightly said, she need not bleed every month. 4 cycles in a year is perfect, considered okay in cases of PCOS. And we all used to prescribe left and right this combination, which all the guidelines are telling us that this is the second line. Yes, Neelam, you want to add anything on this combination? Yeah.
Ma'am, cyproterone acetate came because it was considered as hair reduction and not weight gaining contraceptives. As compared to, there was a lot of talk about these combination of OC pills, but it was in comparison to other OC pills. As such, continuous OC pills for young age are not recommended. But of course, cyproterone has a benefit of less hair growth, and it will reduce the metabolism of the androgens.
Yeah, I'm coming to Ramni. Ramni, as an expert, because our patient is young, 17 years, but she is having hirsutism acne also. So will you prescribe her ethinyl estradiol drospirenone combination or
Yeah.
ethinyl estradiol cyproterone acetate combination?
I think I will prefer going in for a drospirenone with ethinyl estradiol combination, because that drospirenone also reduces the weight of the patient apart from being an anti-androgen. So my choice will be drospirenone with ethinyl estradiol combination. But as rightly Dr. Neelam has said, I will ask her to take withdrawal bleeding only if she is not getting the periods for 60 days. See, rather than putting on the cyclical oral contraceptive pill, that becomes a stigma. Maybe initially, till she gets motivated regarding other lifestyle modification, maybe I will put her on a low dose OC pill, but stop it after some time. I will insist her to take only in the second half of the cycle some progesterone withdrawal. That too, if she is not getting her periods within 16 days. 60 days.
Excellent. So even if your patient is having hirsutism, that is hyperandrogenemia, don't start with ethinyl estradiol and cyproterone acetate combination as a first line. What our expert Dr. Ramni is saying, even in these cases, you have to start with drospirenone combination. Wait for 6 months. And if she is not responding, then you can think of adding that cyproterone acetate OCP.
Or sometimes we can add some other drugs of anti-androgens, like flutamide, finasteride, that can also be added.
Yes.
And always advise her to go for a cosmetic surgery only after initially giving these drugs for few cycles. Then only it will thin out the hair growth, and then you send the patient for cosmetic consultant, so that they will find it easily. The hair will not be very thick. It will be thinned out.
Yes.
So that is what my cosmetic consultant always says. Put them on 6 months, reduce the growth, then send them the patient to me.
Yeah, I want other panelists also to pitch in. I can see they are silent.
Eflornithine cream also we can use.
Yes, eflornithine cream is
also
available.
Something that we can use. It just generally just thins out the hair and makes it less visible. But all these things take time. The effect for them, because hair growth is phasic, anagen, catagen phases. So actually for the effect on the hair hirsutism, it will take easily 3 to 9 months.
6 months minimum. Yeah, another thing is, when you are using eflornithine, don't expose the patient to sunlight. It should not be exposed to sunlight. Only tell her to use it just after the sunset, and that will be ideal.
Okay.
Great.
One more thing is when we are prescribing anti-androgens like finasteride and flutamide, it is very important to put them on a contraceptive and explain the anti-androgenic effect on the fetus as well.
Good point,
Agreed.
Bhunesh. Anybody wants
Good
to add
point.
anything here? Hirsutism, obesity, we have already discussed. Insulin sensitizers. Now we heard a very good talk, but can anybody just summarize ki in which cases you will give metformin, what is the dose, and whether you will give anositol? Just practical message. Any panelist? I can see others are silent because I can't see their faces.
Metformin can be given after lifestyle modifications, ma'am, if needed, and metformin low doses can be added.
Now we are having sustained release preparations which minimize the GI side effects. You can start from the 500, then you can give it incremental doses, and maximum dose is 2 grams per day.
2 grams. With metformin, you need to know that there will be some nausea, vomiting, vitamin B12 deficiency. That needs to be told to the patient. And now the guidelines are that even alone metformin you can give.
Yeah, and that will help in weight reduction also.
That will help in weight reduction. Earlier there was controversy that you cannot give only for weight reduction, but now it is that you can.
You can, yes. And inositol guidelines are saying that there is no benefit, but in our clinical practice, we all are prescribing inositol because we see that it has no harm. On that thing, we are prescribing inositol to these our PCOS patients. Now, this is just the mechanical. Once you refer them to the cosmetologist, they will guide her about the laser therapies and light therapies for hair reduction. And now for acne, because she is sitting in front of you concerned about acne, you are giving her COCP. So can anyone would like to add? Because acne again decreases her self-esteem, her self-image.
Yes. Clostridium containing COCs can be given along with the topical application which we give for acne reduction.
So now we have discussed this androgenism part. Now coming to the impact.
Lakshmi, I would like to add up one more point regarding this hirsute, this acne. Acne, you have to put the patient on low dose antibiotics. Doxycycline, preferably 100 milligrams for 28 days should be used, and with the topical application of erythromycin can be done. And then in cases where the acne is very severe, like a big comedians and then pustules, then you have to have definitely a consultation with the cosmetic dermatologist. Preferably that should be done.
Excellent point, Ramani. Now let us discuss the impact of PCOS on quality of life. So in your busy practice, do you really do something? All the panelists can pitch in. Do you really have a questionnaire in your OPD? Is your sister filling those forms? You are asking them how much anxious they are, how much depressed they are, how PCOS is affecting their quality of life. I want everyone's opinion because this is not often discussed. Rather, we in our busy practice don't pay attention to this aspect of PCOS. Yes?
Ma'am, I'm not using any quality assessment tool, but there is no doubt that it causes significant deterioration in the quality of life. Most of them are very anxious about the fact that they are not getting regular cycles, and the obesity, the body image issues, the pigmentation, acne, all these things add to their additional stress apart from the irregular cycles. And it is very important to manage these people holistically by involving other specialties as well, involving the cosmetologist, the dietitian. So they feel that their management is they are being paid attention. And psychological counseling has a major role to play, especially in these patients who have a lot of body image issues and are suffering with anxiety due to PCOS.
Yes. So even if we are very busy, we have to be aware that it is definitely has an impact on their quality of life, her irregular menses, her hirsutism, her acne, her obesity. And weight stigma is always there because she has to listen to those remarks day in and day out. Array, you are looking fat, you are looking fat. So instead of labeling her as a obese or morbidly obese, the suggested alternative terminology is higher weight. The patient is belonging to a higher weight
Higher
category instead of labeling her as a case of obesity or morbidly obesity. So how you will handle these psychological issues? Now you know that there are psychological issues with these PCOS patient. Even lean PCOS has the psychological issues. It is not only obese PCOS. So how you will handle the psychological issues?
Ma'am, as far as the obesity is concerned, we have to be very sensitive while talking to the patient. And time and again, we don't have to say that you are obese, you have to lose weight. Yes, weight loss is essential, but overall picture has to be assessed. And a good and healthy lifestyle, the importance of good and healthy lifestyle has to be again and again emphasized. She has to be told the benefits of weight loss so that she can actually uh, she can be self-motivated. And again, stigmatizing over weight loss should not be done. A counselor or a therapist should be roped in as a team member, because it has been found that behavioral therapy along with lifestyle modification leads to a lot of improvement in PCOS patients.
Yeah, and again, you
One
have...
more important
Ma'am,
point.
if I may,
Yes, Niharika?
ma'am, I actually always talk to the parents, because most of the times these younger kids who have PCO or on borderline PCO, I always feel that the parents put a lot of pressure about studies, and that is why they are, they're just sedentary, they're just sitting and studying the whole day, or they're in colleges where they start at 7 and come back at 7. They really don't have time. So I think you have to talk to the parents also to tell them that the focus has to shift, the prioritization has to shift. So that is a very important point, I think.
Yes, yes. You have to educate the whole family. And as Apurva was saying about the behavioral therapy, here you have to really focus on her concerns. How much she is concerned about her body image, whether it is hirsutism, whether it is acne, whether it is irregular menses, whether it is her weight. I mean, what is affecting her psychologically, that part you have to address instead of having a general overview, I mean, general psychological issue treatment of that particular patient.
See, another thing is, these girls, young girls, when they are staying in the hostel, see, they don't have the proper food management also. Today, I saw a girl, PCOS, weighing 95 kilos at the age of 17 years. She has just joined her first BA. When I ask her, twice a day, they are giving only rice. So all those things have to be addressed. We tell them, don't take rice, but instead you try to take only the vegetables and try to exercise more and more. And then the snacking, that is very, very important, because these hostel girls, they are in the habit of taking snack. That should also be eating disorders, rightly you have pointed out. So they have either because of psychological disorder, they have eating problems also.
Disorders,
They
and
tend to
yes.
overeat.
Yes, what you are saying, they are more prone for eating disorders as well as disordered eating, what you are trying to bring out. So we should be, as a clinician, we should know that, we should inquire, and this is the behavioral therapy, and then comes to the treatment part. Because they are very, very reluctant to go to a psychiatrist. We are also very, very reluctant to suggest them to go to a psychiatrist, because still there is stigma and taboo. So how you will manage her body image, her self-esteem, because she's concerned, she's having too many cosmetic issues. Yeah, we have already discussed. Yes. Yes, please.
Anxiolytics can be tried, ma'am, if she's very
we can give short-term antidepressants or an anxiolytic at our end.
Maybe
And
they
yes,
can be advised to go to some psychologist instead of psychiatrist.
yes, we advise them to go to a counselor, Ramni, but these and these parents, they just don't go to a counselor. There is still so much, I mean, they just don't know the difference between a counselor and the psychiatrist. They think that we are referring them to a psychiatrist. So again, it falls back on us as a clinicians to take care of their psychological issues. We are taking care of their medical issues, that is managing obesity, regularizing their menses, doing treatment for hirsutism, doing treatment for acne. But all these things takes long time, 6 months to 1 year to show any effect on that girl. And in between these 6 months and 1 year, they really become restless, the girl and especially her mother. that your treatment is not showing. They go on changing the doctors. They hop on from one doctor to another doctor. And again, they don't get the desired result because they are hopping from one doctor to another doctor. So that is why we have to educate the patient, a mother. But yes, at our end, if we feel that she needs antidepressants and anxiolytics, we gynecologists can prescribe the shortest possible duration and the minimum possible dose of antidepressants and anxiolytics. That is what I am trying to tell. And now coming to the very, very important aspect. We all focus only on periods, hirsutism, acne, self-esteem, but we forget the importance of family therapy, which our panelists have brought out, that you have to educate the family. Reproductive health issues, her contraceptive need. Most of our adolescents are sexually active. So do ask upfront and do address her contraception need. Mood and self-esteem, we have discussed. And friends, they do have many future concerns, especially in adolescent girls. Will I become pregnant? Will I have problems in pregnancy? How long I have to take treatment? I am getting married. What should I tell my fiance? So what is your clinical experience? Because this is really a very, very common scenario that our PCOS patients are getting married. And they ask you, just quickly, because we have only 5 minutes left. Because most of we gynecologists tell them that PCOS can be cured. I have seen in practice that they tell you take this 3 months course, you take this 6 months, sab theek ho jayega. Sab theek ho jayega is interpreted as cure. Pregnancy हो जाएगी, सब PCO ठीक हो जाएगा. शादी हो जाएगी, PCO ठीक हो जाएगा. I mean, we talk very loosely about PCOS. We don't take pains and time to educate her that it's a lifelong management. I tell them, जब तक hormones लोगी, period regular आएगा. The moment you will stop, your period might again become irregular. So there is no shortcut like 3-month therapy or 6-month therapy for PCOS. And as far as telling their fiancé and in-laws, we do encourage that it is better to declare. Tell them upfront, but I know many of these, they are not declaring, they just tell them. And then after marriage, they are coming to us. And when you are examining, they are telling, Madam, I had PCOS, I was having irregular menses. But now she is giving you history कि मेरे period शादी के पहले बिल्कुल रेगुलर थे, बस जब से शादी हुई है तब से ही मेरे पीरियड्स इरेगुलर हुए हैं. And as a gynecologist, we can make out what she is talking, but we don't want to disturb their married life. So we also keep mum. We don't document anything on the case paper, and we just get along with what our patient is saying. Now coming to the late sequelae. How many of you really tell the girl and her parents about the late sequelae?
Yes.
We do, ma'am.
Madam, I think diabetes in adolescent PCOS, 3% of the girls are already frank diabetic. And 30% they have insulin resistance. So that we have to tell them. And hypertension is also on the increase, not only because of PCOS, but because of the stress. And metabolic syndrome is seen in about 10 to 15% of the adolescent PCOS girls. That has to be mentioned. And again, regarding the endometrial cancer, I think it is on the increase. And today also I saw one patient with the PCOS with an endometrial cancer, early in situ lesion. So that has to be addressed. The long-term complications have to be addressed in detail to this patient. And initially, as you rightly pointed out, many of the consultants, they say just you take the treatment for 3 to 6 months, that will be all right. But you have to tell them that it is something similar to some endocrine disorder like the thyroid dysfunction, where the woman once becomes a hypothyroid, she continues to take the thyroid drug. So otherwise, what they will do is they will take metformin for some time and then stop it, and they will come back with a florid diabetes. So when we are counseling these girls regarding the management, either be a lifestyle management or a medical management, we should tell them it is a lifelong thing, lifelong problem, and each stage of the life, it has to be managed according to the need of the patient.
Correct. Because her priorities keep on changing. When she is adolescent, her priorities are different. When she is married, she is not able to conceive, her priority is different. At
Yes.
perimenopausal, her priorities are different. During menopausal phase, her priority is different. So as a treating clinician, we should recognize the shift in her priorities as her age advances. Don't forget to tell her about the late sequelae and never do any loose talk that PCOS will be cured. Always emphasize that it's a lifelong management and these are the late side effects of PCOS. Now quickly, we have only 2 minutes left. How you all can tackle. Now we are coming to the prevention part at individual level, not as a clinician. We have discussed everything enough. How you will tackle the menace of PCOS, which is rampant, especially in adolescent population. So what you can do at your level, prevention, what you all are doing, just quickly.
Educating the public about the increasing prevalence of PCOS, advising the parents and as well as in schools, the adolescent girls to follow a healthy lifestyle right from the beginning and follow a very active lifestyle also, avoid sedentary habits from the beginning onwards.
Correct. How many of you are actually been associated with adolescent health educations, going to schools and colleges, because we have to catch them young at your individual level, at your local association levels. You all can do the school and college activities. You all can write blogs, you can do TV and radio shows, and you have to make them aware, because that is the best strategy which we as a doctor can do. Because when as a doctor we are telling them about the diet, they will listen to you, they will not listen to their parents. That is the thing. You should go to school, tell them about the balanced diet, tell them to avoid the junk food, tell them to avoid do the regular exercises. And doctor associations also, we are having a very important role to play as far as prevention is concerned. Our Foxy is doing wonderful work as far as PCOS is concerned, and we are having so many sessions, conferences. We are educating our own members, we are educating the public, we are going to schools and colleges. So this is the last slide. The common pitfall from our side is that we fail to recognize the shifting priorities which we have discussed. We have discomfort with lifestyle counseling. We have time limitations in our busy OPD, and we fail to emphasize or give the multidisciplinary care to these PCOS, whether adolescent or reproductive age group PCOS, because they do need a team work. So just quickly one take away message from all the panelists and experts, and then we will wind up. Yes, I will start. I can see Bhuvneshwari because I'm not able to see all the panelists. Bhuvneshwari?
Start from the beginning. First day when they enter your OPD with the complaints, you just be friendly and start the counseling at a polite way so that they will continue to listen to your advice till they be with you. So it should be a continuous process.
Neelam, your key takeaway for the audience, just one line, quick message. Neelam?
She's muted.
She's muted, I think.
Yes. Sushila Saini, is she here? Then Niharika, you want to say any final takeaway to the audience?
Yes, ma'am. Yes. In addition to dietary and exercise lifestyle modifications, I would say as a clinician, whenever the patient comes, always check for a GTT, make sure you're doing a lipid profile. I think we didn't cover that.
So metabolic syndrome I have covered.
Yes, Ravi, you will be having the last comment.
Yeah.
Yes.
I would want to add something.
So just at the beginning and tell them that it has to be reviewed regularly. I think that is also very important. As you rightly said, tell them it's a lifelong disease. Don't forget that part.
Yes, Vidya, Apurva, Neelam wants to say yes.
Ma'am,
Very
one
frank
point.
and educating them completely about the nature of the disease, that the cycles are going to continue to be irregular and it's not going to be cured like a magic after the OC pill. telling that weight gain is going to be the norm unless they keep working continuously on weight loss and maintenance of the weight. And fertility might be an issue. Many of them might require treatment or assistance with fertility. And explaining to them about the future complications, long-term complications of metabolic syndrome, hypertension, diabetes, and endometrial cancer in the very first visit will definitely solve a lot of anxiety and depression from the side of the patient.
Yes. Apurva has not spoken anything. You want to say anything? Then yes, Ramni, your final key takeaway.
Yeah, the final thing is the disease starts in womb. So when the girl baby is born with overweight, advise the mother to have a check over the further growth profile of the child. Because the mother, another thing is if the mother has got the polycystic ovarian disease, the chances of the child, it is genetic transmission is quite high, and we have to warn them at that stage itself. Then follow up, you tell that each stage, the disease has to be managed according to the requirement of the patient. And in the adolescent girl, weight reduction is very important, dietary modification. Then once when she attains menarche, fairly regularize the cycles, not that it should have been once in a month or so. And then for the cosmetic problems like hirsutism and then acne, all those things have to be managed, and evaluate these girls even at an adolescent age group for metabolic syndrome. Lipid profile has to be done. And if they are, see, not only the obese PCOS, but lean PCOS also, they have to be investigated for metabolic syndrome.
Yes,
So
Ramni,
once when
PCOS also need to be advised lifestyle intervention.
lifestyle modification is a must for the lean PCOS also.
Resistance. So we as a clinician, we don't pay that much attention to the lean PCOS. We give all the attention to the obese PCOS.
Actually, lean PCOS is very difficult to treat. They are very difficult to treat. So then once when they reach the stage of marital status, then they have to be counseled, that not that every woman is infertile. Sometimes they get once in a blue moon menstruation, but they do come out with pregnancy. That can also, miracle can also happen, but always tell them the chances of conception is quite on the lower side. And even if they conceive, don't think that pregnancy is going to be a low risk, because most often these PCOS patients, they have a high risk of developing recurrent pregnancy loss. They have a higher risk of developing diabetes, hypertension disorders of pregnancy. So all those things should be kept in mind, and they have a higher incidence of going in for a C-section or an instrumental delivery. So once when they finish their the reproductive stage, they have to be warned regarding the maintenance of weight reduction, and always see to that their chances of getting hypertensive disorders, persistence of diabetes, coronary artery disease, and especially sleep apnea is a marker for late onset coronary artery disease. That we have to warn the patient. So then finally, probably nearing the end of this menstruation, her cycles might return regular, and that time the chances of conception is also likely to happen, because they have a high AMH level and they have a good adequate reserve. So then in the perimenopausal period, we have to warn them regarding the chances of endometrial hyperplasia and polyps and etc. So holistically, we have to approach this girl who was at a risk of developing PCOS right from adolescent till menopause and even beyond that.
Yes. So our expert Ramni has covered all the take-home messages. I will only say that individualization, they need treatment across life stages. Their priorities keep on changing from adolescent to reproductive age group, perimenopausal, different priorities. And what our expert has said, that once the child is born, they get so busy that they forget they had PCOS. But as a clinician, you should not forget, because she is very much prone for diabetes, hypertension, dyslipidemia, and endometrial hyperplasia. So individualization is the key. I know Rakhi is looking at me, and Rakhi purposefully gave me this topic, and I hope I did justice to your expectations. And thank you all the panelists and experts for your wonderful comments and wonderful take-home messages. Thank you.
Thank you.
Team ICOG, till the discussion is going on, I think let's post a post test, because everybody is waiting for it.
Yes.
Yes, sir.
Sorry.
I've told Neelima.
Ma'am, I
Neelima,
wanted to
please
add some
share
points.
the link for post-test.
Can I
Yeah,
add
it's
something?
already shared.
Neelam, we
Lakshmi,
have already crossed the time. Let's post the post-test as Dr.
it
Parag.
is done. It is done.
Yeah.
So it was a wonderful panel. The panelists also did a good job. I just add one quick comment about counseling. So whenever we are talking to these young girls, what I tend to do is I tell them that you have to control your ovaries, otherwise the ovaries will control you.
Correct.
That's a
So
nice.
then, I mean, most of them appreciate and understand because they have to take control of their ovaries. They cannot uh, allow ovary or ovarian dysfunction, I should say, to ruin their body.
Can I add something?
Yes, Shobha, you can.
Yeah. I just wanted to say something in favor of POC because I think there was a lot of concern about this side. I must say, prescription of POC, even long term, is disindicated in many cases of PCOS, and it helps in correcting the underlying endocrine disturbances actually, and it really mitigates the profile of the disease. And we need not say that it is curable. Definitely, it can become serotonin disorder, provided the lifestyle modification is very consistent. So, we don't say that it's curable. It can become serotonin. These do the women who recover and who do well also, with a very consistent. There is no need to fear about prescription of low dose or contraceptives for this purpose. And they will be acting as contraceptives also. Whereas cyproterone contains pills are not, are not marketed as contraceptives, are not approved as contraceptives by the Yeah. Thank you for the time.
Thank you so much for the opportunity, Lakshmi ma'am. Dr. Parag sir.
Thank you so much, ma'am. Thank you, sir. Thank you, Rakhi ma'am.
Raki, would you sum up today's session in 2 minutes?
Yes, sir.
Raki Madam, I think this has been one of the best webinars in a very, very long time, with such fantastic attendance all the way till the end. It's
Yeah,
been like
good attendance of around 500 plus at 7 o'clock also. That is commendable.
amazing.
Thanks.
Amazing.
Beautifully crafted program by Dr. Parag, Dr. Sarita ma'am, Seema, myself.
No, don't forget the 3 coordinators,
That's what,
yourself, Chaitanya and Seema.
that's what was also. And my dear coordinators, Preeti, Shweta, and Garima. We all
Thank you.
and thank you to everybody with whom the whole program was nicely crafted and done, and with lovely lectures to the point by Dr. Sarita on uterine origins of PCOS and pathophysiology and phenotypes, who could have been explaining much better than Chandrika and Dr. Basab make the things very easy for us on the adolescent PCOS, how they are different and why do we call them as different. And adolescent PCO guidelines very well explained by Minu at length, completing the whole basket of it. And then androgen excess, which I got the chance of speaking it, and insulin resistance and obese versus lean PCOS with at length description about the insulin resistance, why is it and how much it is, and the use of metformin and ionositols, and the leaky gut, that is gut dysbiopsis, very nicely and at length explained by Dr. Shobha. And icing on the cake is by the lifestyle modification, which is a key factor for all the management of PCOS, let it be any type. The first in the list is lifestyle modification with all the key quality of life, which has to be improved by Dr. Lakshmi being the moderator and the experts, Dr. Ramni Devi being there, and a lovely set of panelists which were there. And excuse me, we had good set of uh, delegates joining the whole program. And I think the whole post test is done by all of you. Shall we share the answer?
Asking for answers. They're asking
Yes,
for the
yes,
answers.
because people are waiting for the answers.
Yeah, just a minute.
Yeah. ICOG team can share it. Maybe Raki, if your throat is hurting, Preeti will read out the answers.
Without the answers, or actually they can see it also.
Yeah.
So the first question, the Barker's hypothesis says the correct answer is C. Low birth weight fetus are predisposed to insulin resistance. Yeah, thanks. Type 2 diabetes, cardiovascular disease. The second, epigenetic refers to modification of gene expression. That's answer B. Third, the two-hit hypothesis for PCOS refers to option D, PCOS is caused by prenatal and postnatal influences. Question 4, what is the molecular basis of insulin resistance in PCOS at the cellular level? The answer is C, post-receptor defect in the insulin signaling pathway. Question 5, how does obesity exacerbate the pathophysiology of PCOS? Answer is C, aggravates the insulin resistance and increases the androgen production. Question 6, what is the main cause of anovulation in PCOS? The answer is A, follicular arrest because of insulin resistance and hyperandrogenism. Question 7, which of the following is the primary hormonal abnormality in PCOS? Answer is B, elevated luteinizing hormone levels. Question 8, which PCOS phenotype is considered the most severe in terms of metabolic and reproductive complications? Answer is A, hypoandrogenism with ovulatory dysfunction with polycystic ovaries. Question 9, which phenotype of PCOS is least likely to show insulin resistance and metabolic dysfunction? Answer is C, ovulatory dysfunction with PCOS, that is no hyperandrogenism. So that would be the phenotype type D. Question 10, what is the relation between PCOS phenotype and fertility outcomes? The answer is C. The non-hyperandrogenic phenotype is considered good for better fertility outcomes. Question 11, lifestyle modification includes, answer is D. Beta upar chala gaya. 11 is still left. You need to get this down. Yeah. The answer is D, insulin sensitizers. Question 12, the most common skin manifestations of PCOS is, answer is hirsutism. Question 13, the treatment for acne includes all except, can you put the slide up please? Includes everything except electrolysis. Question 14, the balance of good versus bad bacteria in the gut is mainly disturbed by B, the diet high, which is in sugar and fat. Question 15, the main reason for metabolic endotoxemia is, answer is D, increased permeability of the gut endothelium, that's a leaky gut. Question 16, regarding therapy for gut dysbiosis, which is not true. Answer is D, lean PCOS will not benefit from this therapy. Question 17, the natural source of pre and probiotics are except B, mint and ginger. Question 18, the diagnosis of PCOS is made if two of the three following of the criteria are met: androgen excess, ovulatory dysfunction, or PCOS after excluding. The answer is D, obesity. Question 19, PCOS is diagnosed by the following criteria except, answer is C, obesity of BMI more than 25. Question 20, following statements about the gut microbiome and PCOS are true, except, answer is C, gut microbiome in women with PCOS is less diverse. That was the last one.
Thank you, Preeti. All right, this brings us to the end of day one of this certification course on PCOS. And I must appreciate two women today who are sitting here for last 4 hours, Rakhi and Preeti. Thank you very much for managing the show today. And for the delegates, we still have 2 more days to go. More interesting lectures and discussions. So do join us tomorrow at 4 o'clock for the day 2 of certificate course on PCOS. Thank you. Good night and see you tomorrow.
Thank you. Good night.
Thank you.
Dr. Rakhi, for the opportunity.
Thank you, dear.